Thanks very much, Ziad, and good morning, everybody. So just to mention that I vacated that Deputy Director post when I took some retirement a little while ago, but I'm still there and I have a number of other hats. And I think rabies is very important to discuss at the moment because of the many outbreaks, and also to remind everybody that it's the best example of a One Health disease, where you cannot only work on the human side, but you need to work together with veterinary colleagues to address the problem. It's not moving. Oh, wait, hang on, let's do this. There we are. So all patients and all animals who contract rabies will die, but it's preventable through either pre-exposure prophylaxis, and we'll talk a bit about that, but importantly, through post-exposure prophylaxis, which is almost 100% effective if applied in time and correctly. The most important intervention, though, is dog vaccination. WHO have set a very ambitious target to eliminate human rabies from dogs by 2030. And that's our key reservoir in South Africa. And I think things have fallen back a little bit during COVID, where many of the veterinary teams were redeployed for other reasons. People did not have their animals vaccinated because of COVID lockdowns, and post-exposure prophylaxis was not given in many cases to those who were exposed. People were scared to go to the clinics. Clinics were closed or overwhelmed. So what we've seen in the last 2 years is really a major increase in the number of rabies cases. So over the last almost 5 years, we've had 93 lab-confirmed rabies cases. It's probably only the tip of the iceberg because rabies is often unrecognized. Looks like many other infections or neurological diseases. And if you haven't seen a case, it doesn't always fit the textbook picture. Post-mortem diagnostics are very difficult. You have to get a brain sample. It's kind of everyday practice for vets to get dog brains, but human brain specimens are really quite difficult. And in most parts of Africa, there simply are no diagnostics for suspected human cases. So of the 93 lab-confirmed rabies cases, almost just over 70% were in children, most of them in children under 10, and overwhelmingly, they were due to exposure to rabid dogs. Rabies is, as mentioned, under-recognized in many countries. There was a landmark study from Macmalewa, who's a pediatric neurologist in Malawi, and they were investigating fatal malaria cases in children. And in their quite large sample, they found a number of cases of undiagnosed rabies. We investigate every case of rabies to see what went wrong and to try and correct the problem. And most cases are incorrect management in the health center, either just tetanus prevention is given, rabies post-exposure is simply not given, or just a few doses of vaccine. The category of bite, which is usually 3 from animals, may not include a rig, which may not be available or simply not used as post-exposure prophylaxis. But importantly, not all children, in fact, inform their parents about being bitten. So in our more recent cases, something that's really stood out and is quite alarming is that facial bites have not been properly managed. Bites on the face, the neck, tips of fingers have the highest risk of rabies disease if that animal was rabid. These are the most difficult bites to manage and simply should never be managed in a clinic. They need referral to the local hospital for proper assessment and proper administration of post-exposure prophylaxis, and especially proper management to include rabies immune globulin. Not an easy practical procedure. This is an outbreak that happened in Limpopo in 2004. They hadn't had human cases. Rabies was endemic in dogs and jackal. The number of cases in the animal population increased in 2004, 2005. It was a spillover from the outbreak in Zimbabwe. The vets simply did not talk to the human health people. There was no program for rabies post-exposure on the human side, and a number of cases were admitted to one of the rural hospitals. Very astute physician, pediatrician, noticed that there was an increase in the number of fatal encephalitis cases in children, but she didn't know what they were. She'd never seen rabies before. And their initial diagnoses were typhoid, malaria, polio, meningitis, viral encephalitis, and other. They submitted CSF, which is not going to give you a rabies result, and then raised the flag eventually. And we did get the right specimens, did confirm the diagnosis, and did a review. And in fact, over a year, there were 31 cases of rabies. Once the diagnosis was confirmed, much easier to intervene. Vets and human health people were brought together and proper programs were put in place. So very important to work together. Rabies disease incubation periods can vary, never less than a week. So somebody who comes with what look like signs of rabies the day after being bitten probably has a mom who's been to the internet, seen some scary things, or a patient who's been to the internet and presents with the so-called signs and symptoms. Incubation periods can be perhaps just around a week if it bites on the face or the neck. Generally, they're 12 to 15 weeks, and rarely they're more than a year. I think there are 1 or 2 cases up to 5 years. There is a very non-specific prodrome of fever and headache. Importantly, the patients often complain of a funny feeling, hyperesthesia, at the original bite site. Now, many children don't report the bite, so when you see the child, you don't even know they've been bitten. It happened quite a while ago, so no one remembers. But if there's a complaint of hyperesthesia somewhere, just think about rabies. Different forms of rabies. The furious rabies is the most common. That's where you get the classical hydrophobia, as you see on the left. Give a child a glass of water or run the tap and they go crazy. They have a classic stare in many cases, hypersalivation, and then some spasms. In between all of this, the patient is awake, they're very frightened, and they will tell you about their anxiety and fear. Quite rapidly progressive. Most rabies cases, patients die within a week of presentation. Sometimes the paralytic cases, especially if supported on ventilation, will survive a bit longer, but they will rapidly progress to coma, and death is inevitable. So there's obviously a wide differential diagnosis, and it can range from difficult ones like strychnine, or as we will hear, tetanus, which are not that easy to confirm, to many other causes of meningitis, encephalitis, which need to be managed while you are investigating and awaiting the arrival back of rabies tests. There is only one human rabies laboratory in South Africa, and it does take time for specimens to reach us. We do prioritize them whatever day they arrive. It's important to confirm the diagnosis and in the interim, just manage them for other treatable conditions. So I think ceftriaxone or acyclovir, I think would be prudent to include in the interim. The history of animal exposure and details of that is very helpful, but may not be available. There are no ante-mortem laboratory tests that can definitively confirm or exclude the diagnosis of rabies. Saliva is the least invasive. It needs to be good quality, needs to be taken on admission, because if you decide to do it on Monday, child may not be there, and it's non-invasive. So if it is positive, it's, then you don't have to go for a post-mortem, which is quite a difficult procedure to sometimes access. We haven't had that much joy from nuchal biopsies. It needs to be a punch biopsy, which includes a hair follicle. CSFs are often quite bland. They may show a lymphocytosis. CSF serology and, well, blood serology is not helpful. It may reflect the vaccine administration. If the IgM or IgG is positive in the CSF, and that may only occur if the patient survives a week, that is indicative of rabies disease. It does not reflect vaccination or reg administration. The gold standard is post-mortem brain tissue. It can be a biopsy, which is much more acceptable to family. It needs to be sent to us, not in formalin, and we will do an indirect fluorescent test on it. And you can see an example there. Some of the bloods, the brain specimens get sent for histopathology, but unfortunately, the presence of Negri bodies may be missed. So it's again, not the gold standard. Once you consider the diagnosis of rabies, it really is a case of making patients more comfortable, supporting the family, and protecting health workers. There's never been a human-to-human transmission, and certainly not in the hospital setting, but also not at home. But people are very anxious. You do need to provide personal protection for the healthcare workers, and if they do have saliva in their eyes or mucous membranes, or they're bitten by the patient, patients are often very aggressive, they do need full post-exposure prophylaxis. And importantly, you need to notify the cases, even if it's a suspected case or a probable case or a confirmed case, because that's the only way we can get a sense of how many cases there are and motivate for better vaccination on the animal side and continued availability of very expensive post-exposure prophylaxis biologicals. So, case on the right is Jenna, who was bitten by a bat in the US of A. She presented to a hospital, to a pediatric registrar doing infectious diseases. You'd never seen a case. He did a quick look at the literature, really had no idea what to do, but tried everything. And his decision was to induce coma to try and protect the brain while the patient mounted a good immune response. She already had unusually antibodies on her CSF, and to use a couple of antivirals. She did survive. She initially had some quite severe neurological impairment, but she improved over time. And today, Jenna is a rabies champion and a vet. This protocol has been tried a number of times, but without success. So let's look a little bit about prevention. So virus cannot be transmitted through intact skin. Yesterday, we had a whole family presenting at an emergency department. Their young puppy was ill, had been euthanized. We're still waiting for the results. They hadn't been bitten or scratched, but they were so anxious. They all demanded rabies immunoglobulin and vaccine. And I'm not sure that was appropriate because, you know, the reg does carry a small risk of anaphylaxis. But the virus cannot be transmitted through intact skin. You do need a break in the skin. That could be through a scratch or a bite, and it doesn't have to be large. I think the picture in the middle is the one that most people would go, gosh, bitten by a dog, this must be rabies. One on the left was cat biting with incisors. This was also a rabies exposure. One on the right was, this is the right-hand side now, was a bat bite, very, very small. So it's not the size, it's the break in the skin. Licks of mucous membranes, I think that's a little less clear and much more difficult to decide on how best to manage, but that may also be a route of transmission. And then there have been very rare cases of rabies transmitted through organ transplantation. That's really unlucky. The virus will replicate locally, and at some stage, and it's not clear when, will invade the peripheral nerve and then migrate to the brain. That period from the bite to the invasion is key. So you want to intervene before the virus actually enters the nerve. Bite on the finger, bite on the face, that may be very, very quick. only about 15 to 20% of rabies incidents will result in virus transmission. The others are sort of dry bites, but you cannot tell which are which. So you have to really look at the circumstances and address things very quickly. The virus will migrate at different speeds to the brain, may be very short, it may be much longer, but once it enters the nerve, there is no way of intervening, and that person's fate is kind of sealed. There are no tests, so that's a very difficult period for families, especially if post-exposure prophylaxis wasn't given appropriately, and there are no symptoms. And it's only once the virus enters the brain will you get symptoms of rabies and maybe some positive laboratory tests. So what do we have available? We have only one vaccine at the moment. It's Verorab. It's a cell culture. It's a killed vaccine. You can give it to babies, to children of any age. It can and should be given to pregnant women if there is a risk. The dose is the same for everybody. If it's IM, and we are only using intramuscular as post-exposure, it's 1 amp, and it's either the deltoid or the anterolateral side, never, ever the backside. If it's injected into the bottom, there it will remain and will not lead to an immune response. It's very safe. It's highly immunogenic. There are very few adverse reactions. The vaccine does contain small amounts of antibiotics, so just have a look at that. The big problem is the cost. It's free in the public sector for post-exposure prophylaxis, but not for pre-exposure. The regimens are quite complex, and there are many of them. Importantly, the cold chain needs to be maintained. And I think the biggest problem, particularly in other parts of Africa, is that it's simply not accessible. But most of our hospitals in rabies endemic areas and many of our clinics will have vaccine, but it needs to be given with rabies immune globulin because it only induces immunity 7 to 10 days after the first vaccine. So we're using the second regimen, which is the regimen decided at the WHO meeting and one that we adopted. It's 4 doses, day 0, day 3, day 7, and then the 4th dose, anything between the 14th and 28th day. Day 0 should be the day of the incident, the exposure. If it's not, it still becomes day 0. And even if somebody presents late, 1 or 2 or 3 weeks after the incident, it should still be given the benefit. How well it will work, one doesn't know. If the period in between the bites is not adhered to, it's okay. You know, longer is better than shorter. Just continue. You don't need to start again. Now, absolutely critical, and this is where the biggest errors arise, is rabies immune globulin. We have a human one, not very much. We have an equine one. These are the maximum doses. Only what fits into the wound with a careful technique of local infiltration should be used. So this is a major change. If it's a small wound, you may only use 1 amp. If it's a large wound, you may have to use all the amps. If there are multiple wounds, you may even have to dilute the rig. No, ideally, no local suturing shouldn't be done if at all possible. But if there's any break in the skin, rig must be used if you assess the risk as being one of rabies. The biggest problems are the bites on the fingers, difficult to infiltrate, and ones on the face. And you may have to take the child to theatre to facilitate the administration. If there's no rig available, start the vaccine and get the rig as soon as possible. It's not a license to delay. This is what's going to save the patient. This is what works immediately. We're mostly using e-rig. We're not using a test dose. We've had about 3 or 4 allergic reactions It needs to be given in a place where you can respond to that, to that incident. Be very careful of incisor wounds from animals. They are often missed, and that's been one of the problems in our failure cases. So wound cleaning, very, very intense. You need to use a syringe, lavage the wound out. Sometimes you can physically remove the virus. Clean with alcohol, iodine if it's available, tetanus toxoid as appropriate, same with antibiotics, and then do a risk assessment. Don't send us blood. There's no rabies virus in the blood. There's no antibodies. You need to make the decision about post-exposure prophylaxis on the setting and the circumstances. Don't wait for the result in animals. It may not come. Do a risk assessment. Do it in this order. Mostly there's a break in the skin from an animal bite, and there are many animal bites from animals that are not rabid. Animal species that are not associated with rabies commonly can immediately be excluded. The vervet monkey that chases the child who's got the food. The rock hyrax on Table Mountain biting the over-curious child. The, yes, I think this, the domestic rodents, wild rodents, little rats, little mice, children frighten them and they bite very commonly. They've not been associated with rabies. Be careful of puppies. They have minimal signs and they're often unvaccinated. Ask about the circumstances. Why did this animal bite? Don't use the word provoke to any parent. Of course, they will never provoke an animal. If they stand on its tail or give it some food and try to take it away, they're going to bite. The health behavior of the animal is critically important. We get rabies everywhere. The vaccine status of the animal may be misleading, but importantly, ask about the vaccine status of the victim. They may be previously vaccinated, and then all you have to do is boost them. But don't start from the category of exposure. Almost everyone is a category 3 exposure. So animals with rabies, often tame ones, present with very aggressive behavior. Wild animals, the jackal that comes up to the child in the camp is often a rabid animal, but they're ill. They're drooling, they're unsteady, and they usually die pretty quickly within days. They're not alive 2 weeks later. So the most important is the category 3, the lick of mucous membrane, the broken skin, the bite or scratches that draws blood, and it doesn't matter on the size. And I think we've gone through that. These were all category 3 exposures. They didn't get rabies immune globulin because they looked small, but they were all rabid animals, and they've broken the skin. So, you know, try and avoid that. This was a child scratched by the neighbor's cat. You can see, if you look very clearly, it's broken. The skin is a little scab. This was the category 3. Then the mom went back the day later and in fact found further scratches on the head. We were able to, I guess in time, give post-exposure prophylaxis correctly, but this is the kind of exposure that is missed, and this cat was rabid. Same with this one, relatively small exposure with a bit of secondary infection. Yeah, often easy to miss. Major outbreaks and ongoing outbreaks in the Eastern Cape, in KZN, in major cities, with occasional cases wandering into Gordons Bay and the Strand. That's quite difficult. Children often pick them up, quite a difficult exposure to deal with. Not common, we don't commonly get rabies in bats, but I think, you know, one needs to be cautious, and we're always available to discuss these. So I think my last slide is about prevention. So rabies vaccine given as pre-exposure is standard for vets, given to some travelers going across Africa, but can also be considered for families living in very remote areas where rabies is endemic. And what it does, it obviates the need for rabies immunoglobulin post-exposure. It's the most difficult biological to access. If the child actually doesn't even tell you about the exposure, they will be protected by the pre-exposure doses for many, many, many years. Ideally, if they've been bitten, they should get boosters, but there may be some delay. And, I think it is the safe way to go. It is costly, but it's something to consider if you're living in a game reserve or a remote farm or an area where there's lots of bat rabies. It's a 2-site intradermal. This is a cost-saving, dose-saving. You can give it to the whole family, or you can give intramuscular doses on day 0 and day 7. And it's really long-lasting, with boosters being very immunogenic. When you vaccinate dogs, you reduce the number of rabies cases in humans. When you stop vaccinating dogs, the cases go up. And that's what's happened in the last year. A lovely book that you might want to put in your waiting rooms and share with your patients about responsible animal ownership and teaching children about behavior around animals. So that's my story. Preventable disease, always fatal, one of the hardest clinical cases to manage in a setting where you know what the outcome is going to be. Thank you very much.
Thank you so much, Prof, for that comprehensive overview. We've just got time for 1 or 2 questions. So I'm going to allow those 2 questions in the chats. Prof, if you can answer the 2 questions. The first question is rabies immunoglobulin a Section 21 drug? And the second question is, where's the optimal place to give reg in mucous membrane involvement?
Very good questions. So we do have some supply of human rabies immunoglobulin made in South Africa at National Bioproducts, and that's not a Section 21, but the quantities are very limited for lots of reasons. Unfortunately, the E-reg is Section 21. We've made some attempts to try and get it locally registered, but that's a problem at the moment. So, find out where it's available. In public settings, it is free post-exposure. So just remember, you can refer patients, and some medical aids will pay, but not all. Mucous membrane exposures are very difficult. There's nowhere to put reg. So what they've tried in India, and we really don't know how well it's worked, is to take the reg, to dilute it a bit, and perhaps wash out the eye with the reg. But putting it into muscle is probably of no benefit, and that's why we've changed the reg procedure for post-exposure prophylaxis. Only put what you can get into a wound, but vaccinate, wash out the area, and hope for the best.
Thank you so much.
I must say, all of our rabies cases have been bites or scratches that haven't been managed properly. They haven't been mucous membrane exposures.
Prof, thank you so much. There is some questions still coming through in the chat, and maybe through the next talk.
I can just answer them. Yeah.
Answer them,
okay.
On the talk. Thank you so much for that.
Thank you.
So I'm going to now introduce our next speaker, and the next speaker is Dr. Gill Sorour, who is a pediatric infectious disease specialist at the Rahima Musa Mother and Child Hospital, and she's got years of experience in the field of HIV and adolescent health at the Rahima Musa Hospital. But today she's going to change gears and talk to us on tetanus. So we welcome you, Gill, and we look forward to your talk.
Thanks so much, Liad. So today I'm going to talk on neonatal and pediatric tetanus. And to start off with, I'm going to just present 2 patients. The first is a 9-year-old girl who presented to us in 2020. She was previously well, and she presented to the ENT department with a sore throat, inability to swallow, pain on swallowing. But interestingly, she had no systemic symptoms, no fever. There was also no history of trauma or foreign body ingestion. She was fully orientated with a normal blood pressure. She was a bit tachycardic, but she was apyrexial. There was no obvious abnormality around her throat or in her neck, and her tonsils were not enlarged or inflamed. She had a normal lateral neck x-ray. Her bloods were relatively unimpressive, and the ENTs did a flexible laryngoscope, and it was completely normal. They did a contrast swallow, which showed delayed gastric emptying. And, she was admitted in the ward, and she progressively was getting a bit worse. She was unable to swallow water or secretions. Her mom thought maybe she was faking it. At times, she was unable to walk to the toilet. She was very stiff. And once the ENTs found, all their investigations were normal, they referred her to us. And when we saw her, she was tearful, but she was fully orientated. She was completely aware of what was going on. Her pupils were equal. She was lying stiffly in the bed. She was apyrexial. And she had lots of secretions, and she couldn't really talk to us. She was unable to open her mouth properly, and there was evidence that she'd bitten the side of her tongue. The rest of her examination was normal. It was very difficult to examine her abdomen because it was completely rigid, but we didn't think it was tender. We also weren't sure she had meningism because she had quite a lot of neck stiffness and globally increased tone, but she had normal reflexes. So we went on, further investigated her, but everything was normal, essentially. She had a normal CT, normal lumbar puncture, and normal electrolytes. She was unable to eat, so the decision was made to insert an NG tube. But during the insertion of the NG tube, she became apneic and blue. The registrar thought maybe she was having a seizure. She became very stiff with tongue thrusting. She was resuscitated a bit and loaded with phenytoin, and there was some improvement. Here's a picture of her, and I just want you to notice. She's got this very arched back. She's in this corticate, she's got flexion of her arms and stiff legs. And if you look at her face, she's got this grimace. And the interesting thing is, she was completely aware and, communicating with her eyes, but when she needed to urinate, she couldn't bend. So she could stand over a bedpan, but she couldn't bend. So the stiffness seemed quite an obvious part of it. So she was rigid, oppositonic. She developed this trismus, painful. She couldn't open her jaw. And then worryingly, she had 2 further episodes of severe stiffening, and it caused significant obstruction of breathing, and she actually required CPR, and she became bradycardic. And, we weren't sure, was she fitting, but she had a normal EEG. We asked the mom to bring in her immunizations. She was fully immunized as an infant, but she hadn't had her booster immunizations at 5 years. We couldn't find any evidence of obvious cuts or scratches. There was this lesion on her thigh, which could have been a healed scratch. She was from Diepsloot. The mom said she played in the surrounding areas, and there was barbed wire and stuff around. But, so we weren't, it was quite a difficult diagnosis because tetanus is a diagnosis of exclusion. We asked for a neurology consult. Strychnine poisonings are one thing that can look like this, but it's usually more acute. The dystonic reaction, they often get lateral head turning, and fixed eye deviation, which she didn't have. Her calcium was normal. She didn't have, neuroleptic malignant syndrome with antipsychotics. There was no evidence of her having had any medication. And there's a very rare neurological entity called stiff person syndrome. But unlike tetanus, they don't usually get, trismus or facial spasms, and they usually respond to diazepam, which she didn't respond to. So we treated her with tetanus toxoid vaccination, but we weren't able to access human immunoglobulin. And after discussion with Prof Blumberg, we decided to give her human intravenous immunoglobulin, and she was intubated and transferred to Nelson Mandela Hospital for ongoing ICU care. There she was intubated for about 2 weeks, and they elected to do a tracheostomy to cope with secretions and just to look after her airway. She had recurrent spasms requiring benzodiazepines, but she didn't have any autonomic instability. And here's a picture of her just before they took her tracheostomy out, and she actually did really well. The second case I'm going to present is with permission from Dr. Clarkstorp. This little baby presented to them, a 7-day-old boy. Mom was a 17-year-old scholar, and the baby was primarily looked after by Gran. The baby was a normal vaginal delivery and normal birth weight, was born at an informal settlement in Northwest Province. And baby was sucking well at birth, but by the time he presented at 7 days of life, he was not feeding well, unable to suck, with irritability and episodes of jerkiness or convulsions. His birth weight was 2.9, now he weighed 2.2, so he was really not managing to get enough nutrition, very dehydrated. This is not a picture of him, but just to give an idea, there was had this epistotonic posturing and spasmic movements, and they elected to treat the seizures with clonazepam and phenobarb. Also noted, he had a metabolic acidosis with a low sodium, high potassium, low calcium, but normal glucose, normal lumbar puncture, normal ultrasound, and no evidence of sepsis on his blood investigations. So, you know, they were thinking, was he a neonatal sepsis with meningitis? Was this neonatal convulsions? He had a low sodium and potassium. Could this be congenital adrenal hyperplasia? But his glucose was normal. And in the end, they diagnosed him as neonatal tetanus. He was intubated, given benzodiazepine for seizures, treated with antibiotics, but there was no clinical improvement. And so there was no tetanus immunoglobulin available, and he was immunized with tetanus toxoid. They tried almost every anticonvulsant, and in the end, the medication that worked was magnesium sulfate. So magnesium sulfate, it was chosen because it's a muscle relaxant. It's also vasodilatory. It brings your heart rate down and it stabilizes the heart. So it's often used in neonatal tetanus. Also importantly, he was nursed in a quiet environment. He developed pneumonia, he had periods of apnea, he had quite significant autonomic dysfunction. He would suddenly become bradycardic. He'd also have lots of bronchial secretions. He got massively increased tone and scissoring noted after extubation, but he didn't get any tendon or joint injury or fractures, and he didn't develop hypotension. He was eventually extubated on day 29 and was rehabilitated with a multidisciplinary team. And eventually, you know, despite denying this in the beginning, the grandmother mentioned that cow dung was applied to the umbilicus after the delivery of the baby. And thankfully, this baby seems to have done quite well. He's been followed up, and at 2 years of age was said to have normal neurodevelopmental milestones. So I'm just going to give a brief overview of tetanus. Clostridium tetani, you know, is present in soil, especially heavily manured soil, and it's in the intestinal tract and feces of various animals. It can also transiently be present in the human GIT tract, you know, obviously if you ingest spores. And spores are extremely resistant to heat and antiseptics and can survive for years in adverse conditions. So just to remind us how it's classified, it's a gram-positive bacillus, it's anaerobic, and yeah, it's very large and it forms spores. So this is what it looks like. The mature organisms lose their flagellae and they develop this terminal spore, and they begin to resemble an old-fashioned squash racket. So who do we worry about tetanus in? It's when, you know, Clostridium tetani can only enter through a non-intact skin. So when you get a laceration or puncture in the wound, and then the germination of the spores occurs when they're anaerobic conditions, and then they release the spore, which produces tetanus toxin. And in neonates, they get tetanus when the umbilical cord is cut in with a non-sterile instrument, or when something like cow dung is placed on the cord. So the toxin is tetanus spasmin, that's the one of them. It's a very potent plasmid-encoded exotoxin, and it binds to gangliosides at the myoneuronal junction of skeletal muscle, and it blocks inhibitory impulses. So the muscles are continually contracted. So there are 4 overlapping types of tetanus, and you know, you can get local tetanus, cephalic tetanus, and they can progress to become generalized tetanus. or if you've got some immunity, it might just stay local or cephalic. And then we get neonatal tetanus. So generalized tetanus, it often begins with this risus sardonicus, this contraction of the face, and trismus, where you get lockjaw and masseter rigidity. And you know, the thing that I remember about the child who had it was the abdominal rigidity, and that can often be quite interesting. And then the progression of the disease typically occurs in a descending pattern. The generalized spasm resembles this decorticate posturing, and the patient does not lose consciousness, and they experience severe pain during spasm, and it can be really, really distressing for them. And the spasms are often triggered by sensory stimuli, which is why you need to nurse them in quiet environments and don't stress them. And during the spasm, the upper area can be obstructed or the diaphragm may contract, and both of those will result in respiratory compromise, as occurred in our child. And now that we have more ICU care, this autonomic dysfunction is often the cause of death in these patients. And it presents with hypertension, tachycardia, and hypothermia. And the illness can actually get worse for about 2 weeks because the toxin is transported intra-axonally, and you know, it takes time for that to resolve. This is the risus sardonicus. It's this forced grin with the raised eyebrows, and I do think our child had that as well. And the trismus is this lockjaw, the inability to open the mouth. Epistotonus, this is for the truncal muscles going into spasm, and it can be really painful. And, you know, just to say, there is a entity of local tetanus where you just get local muscle spasms in areas contiguous to where the wound was. But just to realize that this can progress to generalized tetanus. And then when you get lacerations near the face, you can get cephalic tetanus, which is cranial nerve involvement. And again, it can progress to generalized tetanus. So just to talk briefly about neonatal tetanus, you know, the definition, WHO definition of a confirmed case is when all three of these are present. It's when you have a neonate who could suck and cry during the first 2 days of life. And then between day 3 and 28, suddenly they can't suck and they become stiff or they have spasms. You know, a suspected case would be when you only meet 2 of those criteria. And then just to know, the definition for maternal tetanus is any tetanus that occurs in the mother during pregnancy or up to 6 weeks post-delivery or miscarriage or abortion. So neonatal tetanus may occur in infants born when the mother is not immune to tetanus, so she's not been immunized, and it usually occurs through infection of the unhealed umbilical stump. So that's when the stump is cut with an unsterile instrument or dung is placed on it. It's got a very high mortality rate. It exceeds 90%, and developmental delays are very common in survivors. It's completely preventable. We need to make sure that all pregnant women are fully immunized. So what are the poor prognostic factors? You know, it's when a baby presents when they're less than 10 days of age and they have rapid, you know, clinical progression of their disease. And apnea is the leading cause of death in the first week, but bacterial infection of the umbilical stump can lead to sepsis in almost half of infants with neonatal tetanus. And this contributes to substantial mortality despite treatment. So they do need antibiotic treatment for that. So, you know, what is the percentage of neonates who are protected at birth against neonatal tetanus? South Africa has about a 90% protection at birth rate. So we could be doing better. And we need to be, you know, monitoring and making sure that we are on top of tetanus. So WHO are aiming for neonatal tetanus elimination, and the definition of that is less than 1 neonatal tetanus case per 1,000 live births in every district of the country. So neonatal tetanus is going to affect the vulnerable. These are women who don't have antenatal care and who don't have immunization against tetanus toxoid, and often a home delivery and untrained attendant. But obviously it could also occur in women who go to antenatal clinic and don't get a tetanus vaccine. And I think the critical role here is of the surveillance and sharing of findings so that we can make sure that women are adequately immunized. And neonatal tetanus is vastly underreported. Many births occur at homes, and unknown numbers of births and deaths are never recorded. And often babies will die and tetanus won't even be thought of. All right, so just to talk briefly about pediatric tetanus, the diagnosis is actually a clinical diagnosis. You exclude other things, but it's the triad of rigidity, spasms, and autonomic instability. Your differential, as I've been through before, is mostly strychnine poisoning, dystonic reactions, hypercalcemia, trismus due to a dental infection, and stiff person syndrome. Anti-tetanus antibodies are undetectable in most tetanus patients. So there might be a benefit to testing them, but actually there have been some patients who've got tetanus who had protective antibody levels. Culturing the wound is not generally recommended for the diagnosis because it's got very poor sensitivity and specificity. You can also grow Clostridium tetani, and it doesn't mean that it's causing tetanus. So it can be present without causing disease, obviously. So how do we treat tetanus? The most important things, you want to prevent disease progression. You're going to neutralize the unbound toxin. You can halt the toxin production with antibiotics and source control. You're going to clean the wound. You're going to ensure intact, protected airway with appropriate ventilation. Control the tetany and the spasms. And just remember their high metabolic needs. You need to provide adequate nutrition and adequate fluids. So you neutralize the unbound toxin by giving tetanus immune globulin. And there are various preparations. You get human immunoglobulin, and there is also equine, but the problem is availability. And just having tetanus does not make you immune and prevent you from getting tetanus again. So everyone who's had tetanus needs to be vaccinated. All right, and ICU management in a quiet area, intubation. Control the spasms with benzodiazepine, propofol, and magnesium. Because of the increased metabolic needs, you need to get adequate nutritional support. You can get spasms of the bladder, so you need to catheterize, and then good rehabilitation. The disease usually lasts 4 to 6 weeks. Neonatal mortality rates are much higher. So I think ultimately we need to emphasize prevention, we need to immunize, we need to get prophylactic wound management and hygienic practices during childbirth. All pregnant women should have 5 doses of tetanus toxoid. We should be immunizing women during every pregnancy. If they haven't had baseline immunizations, ideally we want to give tetanus toxoid 4 weeks apart during pregnancy. So post-exposure management for tetanus-prone wounds, you're going to look at the immunization history, and if it's a high risk for tetanus, you would also give, you would immediately give the vaccine, and you might even give tetanus immunoglobulin at a different site. So in South Africa, neonatal tetanus has been eliminated since 2002. There were 7 cases notified in Jan to April of 2020. And, I think we're not picking up most of the cases. Just please remember, you need to notify. It's a category 2 notifiable condition. And prevention is really central to management of this this disease because there's a high mortality even with the best treatment. Great. Thanks so much. And just say thank you, to the doctors at Klerksdorp.
Thanks so much, Gill, for that clear and comprehensive overview on tetanus and 2 lovely case examples. I don't see any questions in the chat, and unfortunately we have run out of time. So I'm going to ask the audience if they do have questions for Gill to please put it in the chat, and maybe Gill, you can just answer them as we go along. So really thanks to both our speakers for their talks this morning. And I'm now going to hand over to James, who's going to chair the second session on HIV and TB. Over to you, James.
Thanks, Ziad, and thanks to the first 2 speakers for great talks. I'll chair the next session, session 2, which will focus on HIV and TB. We all know that there's lots of changes in the HIV world, and fortunately, we're finally seeing some changes in the TB world as well. We're doing well for time. I think we started about 5 minutes after 8:30, so we're not too bad. We're a couple minutes over. The first talk will be given by Professor Mo Archary, who's a colleague and is a pediatric infectious disease specialist in the Department of Pediatrics and Child Health at UKZN, and is very involved in HIV and TB guidelines at national level, at WHO level, and has a strong interest in resource limited setting optimization of HIV treatment. So Mo, we're looking forward to your talk. Thanks very much.
Thanks, James. And I think thanks to the audience for joining this talk. And again, initially, I think we were planning to go through some cases and look at advanced, interesting cases around complex HIV care. But things changed so rapidly in the HIV field, and we were really excited that there were quite rapid improvement in terms of the number of new formulations that were available. So we kind of changed track, and really will give you a sense in terms of where the new changes are going to be. And it's an exciting time for pediatric HIV that's really been left behind in terms of getting optimized treatment for children. So I'm going to go through what are the best treatment options for children with HIV, and we'll speak about both in terms of a South African setting, but also in terms of a global setting, and both private and public health setting, where options are slightly less expansive. So we'll go through what is the landscape, the gaps in the cascade, and we'll look at the treatment across the age spectrum, and that includes newborns less than 4 weeks of age, children between 4 and 10 years, and then teens over 10 years. And look at what are the current options available, in the new options available, and the long-term landscape for pediatric HIV. So I don't need to dwell on this side, but we've done quite well in terms of dropping the new number of new HIV infections, but it's still quite significant. So around 150,000 children newly infected with HIV, and with a significant amount of deaths still occurring. And as you can see at the bottom, around half of those are occurring in Southern and Eastern Africa. And if you look at South Africa, again, we've dropped the number of new HIV infections, and really, we pale in terms of the numbers of new HIV infections, compared to the adult colleagues across the age spectrum. And that largely is due to, relatively successful PMT-CT program that really is able to close the gap in terms of new HIV infections. But it still leaves us with a large number of children who require antiretroviral treatment, which will be for the rest of their lives. And these kids will then advance into adolescence, into adulthood, which is an ongoing need in terms of treatment for them. So how are we doing in terms of the cascade? And you can look at this is from the 2020 treatment cascade global outlook. And you can see there's quite significant differences, across the different cascades. And just to remind you, our ideal is to get to 95, 95, 95, and that's 95% of HIV, individuals with HIV being diagnosed, 95% of them being on treatment, and 95% of them being suppressed. And you can see on the left, the rates across pediatrics is significantly lower compared to adults. And that goes all the way in terms of from the diagnosis. And although we've improved in terms of identifying HIV-infected children, specifically around the birth HIV testing and improving, closing the gap, what we do find is that we're still losing children with delayed diagnosis, with breaks in that that diagnostic repeat testing that occurs outside of that birth testing. And if you look at the the viral suppression cascade, and again, and these are global figures, the adults are around 67%, and 40% for children. So again, significantly lower than viral suppression rates in children compared to adults. And this, although there's been some improvement across the time, it's really been quite negligible for children. And if you look at these, the figure at the bottom, which looks at PEPFAR-related countries in terms of the viral suppression rates, and you can see across the age spectrum for children, it's significantly lower compared to the adult colleagues. And this is some data from that was presented this week, from South Africa, that again looked at the treatment cascade in South Africa. So the adult cascade at the moment is sitting at 93, 78, and 89, and you can see again in children, although 80% of children who are HIV infected or living with HIV are diagnosed, the cascade falls down quite quickly thereafter. So it's 59 for those going on to treatment, and only 63% of those who are on treatment who are biologically suppressed. The other interesting thing is, if you look at that figure on the top, the other area where there's quite a large drop is the viral load done. So again, I think one of the difficulties, especially with children and the volume of bloods done, even with children on antiretroviral treatment, are less likely to have a viral load done compared to the adult colleagues. And again, the figure at the bottom is from the NHLS data. And these are kind of skewed because these are kids who are actually having viral loads done and are in the system. But just to illustrate, if you look at suppression rate, and the orange bar is the children who have green is the viral loads less than 50. The orange bar is between 50 and 1,000, which is unsuppressed, but undetectable, but suppressed according to the WHO guideline. And the red bar is really unsuppressed individuals. And young children, so less than 5, are the highest burden in terms of poor virological suppression. So I think the question is really, why does this happen? And I think there's several reasons for that. There's context issues in terms of pediatrics that make it difficult, especially where there's an additional caregiver that's a barrier, that's a stopgap between the individual who requires a treatment and the intervention itself. And really that caregiver and that ability of the caregiver to navigate many of these unique adherence issues really affect the ability of biological suppression to occur. That includes, parental guilt, non-disclosure, poverty, distance from clinics, denial, changes that we often see in caregivers that impact on child health, treatment fatigue, the pull burden in terms of the number of treatment that's needed, and stigma around the disclosure of treatment, both in terms of the child, but also in terms of to other family members as well. But the other major issue is really around the difference in terms of pediatric treatment versus adult treatment. And we're all well aware in terms of that the adult treatment is really around simplicity, and being able to give a highly potent fixed dose combination treatment once a day is really chalk and cheese compared to what we offer to our children. And that's a rather complex and sometimes less potent regimen with individual formulations, and we all know some of those formulations are horrific to be able to take once a day, but we have to take it multiple times a day. That really makes it very difficult for both the child to be able to adhere to it, but also for the caregiver to persist and maintain on that treatment. And there's really been some, quite a bit of activity around trying to simplify treatment and move to more simplified fixed dose combination ART and get us closer to where the adult treatment regimens are. So what's the current status of the ART regimens, recommendations, and the figure on the left looks at the WHO recommendations, and these are for term neonates. So the WHO recommends a combination of AZT, 3TC, and either nevirapine or raltegravir for neonates, so that's less than 4 weeks. The combination for young children between 4 weeks, which are 3 kilograms and 30 kilograms, is a combination of abacavir, 3TC, and dolutegravir. And then for children over 30 kilograms, it's the adult formulation of tenofovir and XTC, which is either 3TC or emtricitabine, and dolutegravir. So very similar to what the adult regimen is. The recently updated DHHS guideline, which is the US guideline, has gone slightly further from that, and one of the major differences, and we'll have some discussion around that, is the extension of abacavir 3TC down to term neonates. So using abacavir 3TC as a backbone NRTI regimen from birth for all infants, and that's recommended or preferred NRTI backbone. And then they recommend a combination of TAF, which is a tenofovir alafetamide, which is a prodrug of tenofovir that has a less renal and bone toxicity compared to tenofovir. So that's registered from 14 kilograms and 2 years, and the recommendation for children over 2 years and 14 kilograms is to use a fixed dose combination of TAF, FTC, and bictegravir, which is a similar integrase inhibitor to dolutegravir, which has a very similar genetic profile to that medication. And then for that group in between 4 weeks and 2 years, a combination of either abacavir, 3TC, and dolutegravir. And then for the neonates, which is less than 4 weeks, is used either to use a combination of abacavir, 3TC, either nevirapine, raltegravir, or lopinavir ritonavir from 2 weeks of age. The South African guidelines, again, is on and this is the 2019 guideline. We had recommended AZT, 3TC, and nevirapine for the neonatal cohort. For the young children between 3 kilograms and 35 kilograms, which is we recommended abacavir, 3TC, and lopinavir ritonavir. And then there was a supplement and then change, and we extended the use of dolutegravir down to 20 kilograms. So in children over 20 kilograms, between 25 and 35, could go on to abacavir, 3TC, dolutegravir, and then for over 35, go on to the fixed dose combination of tenofovir, 3TC, and dolutegravir, similar to the adult colleagues. So one of the major changes is really around this availability of the dispersible dolutegravir tablet, which is an exciting era for pediatric HIV, which really allows us to provide fixed dose, poorly well-tolerated medication for young children. So one of the major difficulties in trying to navigate these age ranges is really around closing the gap. And what you can see is this incomplete access to drugs across the age spectrum for children. So if you look at abacavir, it's only licensed from 3 months of age, and there's additional PK data, and that's modeled PK data that expanded the recommendation, and the US recommendation has now gone to birth for all children for abacavir. 3TC, similarly, there's some data, PK data from the PMT-CT regimens that we've used that can be used in children over 32 weeks of age. AZT, again, there's data down to term neonates, and there's PK data from PMT-CT regimens for prem babies. And similarly, if you go down the line, you can see it varies across the age ranges where some of these drugs can be used. And that really does complicate the guidelines where you can use some drugs in certain ages, but you can't use drugs in other ages. And that really makes things a lot more difficult in terms of developing, cohesive, easy to use regimens that you can use across the age ranges for children. And I think one of the things that spurred this talk was really this SAPRA announcement. And in one fell swoop, they sent out a media release where they proved both a 4-in-1 Baclofen 3-TC lopinavir-ritonavir granule formulation. And again, it's the first time it's been registered in the world, which is again something different for SAPRA. And it also, they approved the dolutegravir 10 milligram dispersible tablet, which will allow us to use dolutegravir down to 4 weeks of age in children over 3 kilograms in weight. So again, I think exciting times for pediatrics, and really, we're all looking forward to moving away from lopinavir-ritonavir syrups in young children. So going through the age ranges and what are the recommendations? So in adolescents, over 10 years and 35 kilograms in the South African guidelines, and WHO goes down to 30 kilograms. There's significant advantages for alignment with adult guidelines, and it's TLD. There's a need to monitor the creatinine clearance and look for issues around this. There's concerns about weight gain and neuropsychiatric symptoms. The study that provided the evidence around this was Odyssey, which looked at compared a dolutegravir-based regimen versus a standard of care-based regimen, both for first-line and second-line treatment. And and it included both a backbone regimen of Baclofen 3-TC and TDF-FTC in your first line, or AZT3-TC in your second line. So the headline, results of the study was that it found that dolutegravir-based regimen was superior in the main trial in children over 14 kilograms, both in terms of biological failure and clinical failure, compared to standard of care, which was either lopinavir-ritonavir-based care treatment for young children or efavirenz-based treatment for older patients. And that was both for first line and second line. And Odyssey A was for first line, and Odyssey B was for second line. And just to answer the question around other changes, so the CD4 counts were slightly improved in terms of their dolutegravir versus the standard of care. The weight gain issue, there was some very minimal changes in terms of the difference in weight gain. And if you look at the last bullet point, overall, there were 25 children who were newly diagnosed as overweight or obese at 96 weeks. 4% of them were on the dolutegravir arm, and 3% over there on standard of care arm. So there was no difference in terms of the number of individuals who became overweight on either of the different arms. So again, slightly different from the adult treatment. Similarly, in terms of the neuropsychiatric manifestations, they were much less compared to standard of care. The alternatives, and again in South Africa, what's available for adolescents include a fixed dose combination of TAF, lamivudine, emtricitabine, and dolutegravir, and that's available as a once daily tablet. There's tenofovir, emtricitabine, rilpivirine. Again, it's available as a once a day tablet. There's tenofovir, emtricitabine, efavirenz, our old TE that still works for some patients, and patients may have adverse events with dolutegravir, may not tolerate it, may need to go back onto this older regimen. And then there's Tymecu, which is a Baclofen 3-TC dolutegravir, which is again a fixed dose combination tablet once a day for use in children over 35 kilograms. The other alternatives, globally, there's TAF, emtricitabine, bictegravir. Again, it's a once a day fixed dose combination, well tolerated, less renal toxicity, and there's a new pediatric formulation that's been licensed in the US, and that's allowed the recommendation to go down to 14 kilograms. And then very excitingly, the first injectable formulation was approved by the FDA and the EMA allowing for the use of cabrylpulverine, long-acting injectable formulations in children over 12 years and over 35 kilograms, and it's given as an alternative every 2-month injection. And it's a stable switch, so you need to be biologically suppressed without prior evidence of NNRTI or INSTI resistance before going on to this regimen. For infants, I think what we're going to move to is really abacavir 3-C, which is a fixed dose combination of abacavir 120/60 dispersible tablet and dolutegravir 10 milligram dispersible tablet, and that's the the one that we're going to probably we are going to go to, and at the moment there's a lot of activity around updating the guidelines and getting the procurement process in order for us to get access to this medication. So the abacavir 3-C dispersible tablet was launched last year. So if you look at the bullet, the figure or the table at the bottom, and look at the last figure. So if you look at the abacavir 3-C dispersible tablet, that's 3 tablets once a day, versus if you're using the syrup formulation, that's 10 moles abacavir and 15 moles of 3-C twice daily. So that's 25, 50 mils of syrup that a child has to take twice, compared to 3 tablets that they can disperse in a liquid and be able to take orally. And then the dolutegravir dispersible tablet, which is a scored distillable, so it breaks up into 2 equal quantities, and it's 5 milligrams in each of those. So what it'll look like is if we go down to 3 kilograms, is the simplicity. So if you between 3 and 4 kilograms, it's 1 tablet of the abacavir 3-C dispersible tablet and half of the scored 10 milligram dispersible tablet of dolutegravir, and it goes across that range. And it's not only easier for patients to take less medication that they have to take home, but it's significantly less costly for the Department of Health. So there's multiple different advantages of moving to these newer formulations. So this is how you administer it. So you put the tablets into 10 to 20 mils of water, swirl it around, and then you drink completely. If there's any residue, you add a bit more water and get the child to drink it. And again, it does allow the option of children to then can swallow the tablet completely if they want to, as an option, and allows that easy navigation between a liquid formulation where they need to take it orally as a liquid, but then when you're trying to train them to take a solid tablet, you can then allow them that flexibility to move to that solid tablet using the same formulation, which is often difficult with other formulations. So this is what the guidelines will look like, and really, again, it will make it much simpler for children. And then these the results again from the Odyssey trial from the under 14 years, and again, I won't belabor the point. What it showed was the dolutegravir-based treatment was superior compared to the standard of care. So again, this move towards this optimized treatment for these young children. Alternatives include, the abacavir 3-C dispersible tablet with lopinavir ritonavir, TAF FTC with dolutegravir, and that's over 20 kilograms, and there's a 200 milligram tablet, and then abacavir 3-C, lopinavir ritonavir fixed dose granule formulation. That again, this is a new formulation which tastes extremely, it's a strawberry color, it's a strongly flavored formulation that's easy to use and can be used as an alternative to a dolutegravir based regimen in patients who are not able to tolerate it. Other formulations that are available, there's a fixed dose of abacavir 3-C dolutegravir, that's dose formulation, 60-35 milligram, that's registered by the FDA, but it may be a while before the generic manufacturers are able to provide that. But at the moment, we've got almost the equivalent in terms of a simple once-a-day regimen for children. And then, as I spoke about, was the TAF FTC bictegravir. And lastly, I think just so on the horizon is the cabrylpulverine in young children. That's an ongoing study. Again, we'll have some data probably next year or the following year around that. and then the TAF FTC bictegravir. For full-term infants, I think, currently we're recommending, AZT3DC nevirapine as individual formulations from day naught. The EDL does give you the option of starting abacavir 3DC, lopinavir, ritonavir, and this is the dosing table, which is very similar to, it's exactly the same as the US guideline of using abacavir 3DC from 14 kilograms, 14 days of age at these doses. Again, allowing that simplicity for moving them on to their eventual regimen when they grow up. And we may consider, you following the US guidelines to recommend abacavir 3DC down from birth in the future. So the alternatives is using, abacavir, lamivudine, and raltegravir granules. Again, it's slightly more labor intensive and comes with a whole lot of mixing guidelines that can be difficult to use. Alternatives, again, there's a few studies looking at abacavir 3DC dispersible tablets, granules, and also dolutegravir. And there's 2 studies looking at getting dosing guidelines for dolutegravir from birth. For the preterm infants, we haven't really had much headway apart from we've got slightly better dosing guidelines, and this is from the EDL guideline recommending AZT3DC nevirapine as individual syrup formulations from birth until the child reaches 42 weeks corrected gestational age, and it's very similar to the US guidelines and the WHO guidelines. So what the future landscape looks like, it's really around getting to long-acting formulations, either as oral long-actings or other injectable formulations, broadly neutralizing antibodies as subcut injections, and then these microarray patches, which again is very early in development, which can be adhered to the skin and then provide you with a week or a month amount of treatment for children. So these patches, you put it on the skin, leave it for a minute, remove the patch, and it puts in these micro needles into the dermis, which then slowly releases medication into the patient. And again, that's probably another 5-10 years away before we can see those products coming onto the market. So I think in conclusion, I think there's major advances in terms of simplifying child-friendly treatment options for ART across the pediatric spectrum. Unfortunately, young children, especially premature neonates, have the least number of options. And I think it's really quite gratifying to see that from having no options, we have several different options available for use in children to provide treatment for them. And so there does need to be innovative research strategies to try and close a gap. And we often speak about these washout studies, which will be able to give us these PK data, especially for very young children, very early in the development of those drugs. So you do these PK studies in children who are exposed to mothers on this treatment. And the priority is to translate this improved access to child-friendly ART regimens to tangible improvements in achieving the 95-95-95 targets. And that really requires all of us to work together, to make these changes for child-friendly regimens, to have actual benefits for the patients that we see. So I'll stop there, and hopefully we'll have some time for questions.
Thank you very much, Mo, for bringing us all up to date with some of these very exciting developments. Finally, we almost faced with options, and it'd be interesting to see how the guidelines keep this manageable and relatively simple for the non-PID specialist or pediatrician to actually take on this treatment at a decentralized level. I'm not seeing any questions coming through in the chat, but if there are, please do proceed with posting questions, and Mo, hopefully, I know he has to leave, but could address if there are any questions. I think at the moment it's 9:55. We're running kind of on time, so 5 minutes later than the starting time, which is when we started 5 minutes late. So I think we'll carry straight on. The next speaker is Dr. Nosisa Sipambo, who is head of the Harriet Shezi Children's Clinic at Chris Hani Baragwanath. pediatric infectious disease specialist, and has a lot of experience, clinical experience, research experience with HIV and TB in children. And she's kindly agreed to take on the topic of TB, some of the uncertainties around investigation and management, and some of the developments happening in the TB world. Thank you very much, Nosisa, and looking forward to your talk. Thank you. I'm not sure if you muted, Nosisa.
Was definitely muted. Good morning, everyone. Thank you for the committee for inviting me. And sure you can hear me now, right, James?
We can hear you well. Thanks, Nosisa. Great.
Okay, great. So without any further ado, I will take it away. And finally, there are some changes happening in the TB world. And in fact, in the next couple of months or years, the TB world is going to start looking like, the HIV, or even perhaps not quite the COVID era, because that was quite fast changes that we experienced in the last 3 years or so. Okay, so next slide. Okay, this is frozen. Where is the next slide?
Have you got an advanced arrow at the bottom left there on your screen?
No, I don't. Oops, okay, that was next slide. Okay. So we're going to do a very quick introduction and quickly move on to focus on TB diagnosis, TB treatment, looking at the regimens, durations, the formulations, and then conclusion, and then the future. And I think you will see from this, because this is a 30-minute talk, that it really only focuses on TB diagnosis and TB treatment, and also focusing on just drug-susceptible TB. So TB is actually estimated to be having been around for at least 3 million years. In ancient Greece, it was called phthisis, and in the 1700s, it was called the White Plague, due to the fact that TB patients looked quite pale. And in fact, TB patients look pale still today. In the 1800s, it was called consumption, and later on, it was called a captain of all these men of death. And it remains so till this day. In terms of children, globally, 1.1 million children are infected with TB and fall ill with TB disease every year. And this constitutes about 11% of all TB cases globally. And 20% of these kids, just over 20%, actually die from TB disease. When we look at the global map of TB incidence, you can see that South Africa really is one of those capitals of the highest TB burden areas in the world. In 2019, this incidence was 615 cases per 100,000 population. And in 2020, dropped down to just 554. But this is thought to be more of underreporting and decreased case detection because of the focus around COVID and the disruptions that were caused by COVID, not a true drop in incidence. And so South Africa is one of those high TB burden areas, and the highest burden is in children that are less than 5 years of age, so the population that we deal with. So moving on to TB diagnosis. So young children have paucibacillary TB disease and cannot easily expectorate. And thus the diagnosis is often based on a composite of a whole lot of different factors, especially in the absence of a TB bacteriological confirmation. So you will require to take a careful history that tries to elicit symptoms that are common with in terms of TB, but that is non-specific, as well as eliciting a TB contact history. Clinical examination that includes growth assessment, HIV testing, because there's quite a lot of co-infection, that patients that are infected with TB often are HIV infected, and high prevalence of TB in HIV infected patients. TB bacteriological testing, chest X-ray and AP and lateral for kids, young children, and then TB infection testing and relevant investigations for presumed extrapulmonary TB. So who are we going to test for TB? So we start off by eliciting a positive TB contact. And having said this, this is only found in about 50% of kids who confirmed TB. However, you should still take the time to elicit a positive TB contact, establishing whether this patient has been exposed to an infectious TB case. Once you've got that positive contact, and also taking the time to explore the drug susceptibility profile of the TB contact. Because in the absence of bacteriological confirmation, which includes drug susceptibility, you might need to base your treatment on the drug susceptibility profile of the contact. You need to be aware that even though young kids, mostly it's a household contact, the older the child is, the contact could be at creche, at school, other settings. And this child is presenting now with a clinical picture that is compatible with TB disease, but that contact could have been in the last 2 years or so. So extending that investigative time as well. So the other thing that you will need to do is screen for TB symptoms. And these would include an unremitting fever, fatigue, weight loss or growth faltering, a persistent cough, and then the latter two with hemoptysis and night sweats are more in older kids that tend to present more like adult cases. So 10 years and above, your adolescents tend to present like adult patients. And one thing that really improves that diagnostic yield is doing a chest X-ray on patients where you've got access to a chest X-ray. And that's just a normal chest X-ray of an infant with the thymic shadow there. So all HIV positive patients need to be tested investigated for TB as well. Children with severe acute malnutrition. And prior to immunosuppressive therapy, you would minimally need to determine whether this child has got TB infection and they are eligible for TB prophylactic therapy. Because once that immunosuppressive therapy starts, then you know the patient would have very likely progress to TB disease. And so you would also need to investigate anyone where you've got a clinical suspicion of TB. So looking at TB infection versus TB disease. So we've already mentioned that, you know, you need to establish that TB contact. And that positive TB contact is enough to establish the premise of TB infection. But if you want to prove TB infection and you've got access to these tests, so you can go on to do a tuberculin skin test or the interferon gamma release assay. Now, both of these tests are looking for an immunological reaction and are prone to the same false negatives, in the sense that very early on, prior to developing that T-cell specific response to TB antigens, your tests are going to be negative. Patients that cannot produce that immunological response, either because they've got HIV infection, severe acute malnutrition, they've got other immunosuppressive diseases or primary immunodeficiency disorders, or even immunosuppressive drugs, would not be able to mount that immune response for you to confirm that they've got The IGRA, even though it is less accessible, certainly in the public sector, has got the one advantage over the TST in that it is not influenced by BCG vaccination, as well as other microbacterial diseases, because it tests MTB-specific antigens, the immunological response specific to those antigens. So looking at some respiratory specimens that you will need to send for patients with suspected pulmonary TB. So these are the various specimens, and the one that we are most familiar with is sputum, which can be induced or spontaneously expectorated. This has the disadvantage that young kids, it's not a specimen that you can obtain from young children. In settings where you are doing an induced sputum, be aware that the appropriate infection prevention and control measures need to apply to prevent transmission to the rest of the children or anyone else around the procedure. Gastric aspirates is what we use a lot in, because this can be done in young kids. However, it does require the fasting prior to that. Nasopharyngeal aspirates are less invasive than gastric aspirates and can also be done with an induced, with sputum induction before getting the nasopharyngeal aspirate. And the newest specimen is stool, and this is considered to be a respiratory sample in the same sense that gastric aspirates are considered to be a respiratory sample. So this has been approved by a WHO and is currently available in Lancet and Empath, and NICD has just finished their validation process for stool as a respiratory sample testing for TB. So I think this is one of the things to look out for when it's going to be available and how is it going to be available in the public sector. So you need to send off one respiratory sample for molecular testing, and in which case in South Africa, we are all using Gene Expect Ultra, which has a greatly improved sensitivity. And then a second respiratory sample for TB microscopy culture and sensitivity. Of note, stool cannot be sent for microscopy culture and sensitivity. So the sensitivities and specificities you see over there is for the Gene Expect Ultra. The radiological investigations on the whole support a clinical diagnosis of TB. However, be aware that they are non-specific, and there's a very high inter-observer variability in interpreting the radiological investigations. They can also be used for monitoring response to treatment, as well as evaluating for extent of disease and complications. The chest X-ray is the most accessible and common one that we are all familiar with. And current chest X-rays use less radiation than previous chest X-rays. And in the presence of a TB contact, positive TB screen, plus any abnormality on chest X-ray, this really increases the sensitivity to 80% and specificity to 91% of the patient having a TB disease. Ultrasound is an emerging modality for evaluating mediastinal lymphadenopathy. However, it is highly operator dependent, and as a new modality, a lot of people still don't have the skill in using ultrasound for this. And there are limited windows in looking at mediastinal lymphadenopathy through an irritated lung. You can't see hilar adenopathy using this modality, but it has the obvious advantages of an ultrasound. Then CT chest, it can detect early changes before they become apparent on chest X-ray. And MRI has similar utility to the CT chest. However, even more decrease in challenges with accessibility and then the requirement for anesthesiology. So there's a chest X-ray of an infant with perihilar lymphadenopathy. You can see on the arrows there. And then that is the donut sign showing once again the perihilar adenopathy. And then the bottom one is a miliary picture on the chest X-ray. So for patients that are infected with TB, you need to do an HIV test to determine whether they are HIV infected as well. And those that are HIV positive, then there's an additional bedside test that can be done, which is the urinary lamp. The greatest utility of the urinary lamp is actually in HIV-infected adults with a CD4 count of less than 100. And the sensitivity in adults goes up to about 83%. With children, there's a lower sensitivity, but 48 to 73%. And there's been studies that have demonstrated utility in HIV-negative children with severe acute malnutrition. Of note is that the specificity is 80%. Thus, you can get false positives, especially with kids where the collection of that specimen could have been a urine bag, because it doesn't need to be a sterile specimen. It just needs to be a fresh specimen. So with a bag specimen, gram-negative bacteria can cause a false positive urinary lamp and even infections like nocardia. HIV-infected kids need to be evaluated pre-initiation for pre-initiation of ART, and if they're already on antiretroviral therapy, monitoring for response to treatment. So for patients with extrapulmonary TB, then they would need a collection of appropriate specimens from affected sites and sent for molecular studies as well as microbiology and chemistry and histology as appropriate. So moving on to TB treatment, over the ages, TB treatment has gone through various evolutions. And the Romans were the first to come up with a moderately successful regimen of fresh air, rest, nutrition, sunlight. And obviously this was not accessible to the lower classes. It was only the upper classes that could afford this change of environment and scenery. And in 1943, the discovery of streptomycin, it was the first antituberculous drug. And this was 60 years after Robert Koch had announced the discovery of Mycobacterium tuberculosis as the cause of TB disease. This was soon followed by the discovery of PAS, launching combination therapy. And in 1951, the discovery of INH launched triple therapy, which allowed a decrease in resistance that had been seen with streptomycin monotherapy and even combination therapy with PAS. And further increased the efficacy, and the duration was now 24 months. With the addition of ethambutol, this duration dropped down to 18 months. Rifampicin, together with INH, one of the most powerful and efficacious TB drugs, that dropped down to 9 months. And from 1972, the discovery of PZA gave us what we've got as a 6-month regimen. So this was a long time ago that we've got this regimen that is for 6 months. And of note, what we are using in pediatrics is extrapolated from studies that were done in adults. But I think this highlights the importance of combination therapy, what combination, and this look at those combinations can result in reducing the duration of therapy. So enter one of the most exciting studies in pediatrics, shorter treatment for minimal tuberculosis in children, SHINE trial. And if anyone knows how they got to SHINE from shorter treatment for minimal tuberculosis in children, please tell me. Anyway, this was a pediatric study where they evaluated just over 1,200 children who had non-severe TB disease. And there was a specific definition for non-severe TB disease. It had to be postbacillary, non-cavitatory, confined to one lobe, if there was a consolidation in the lungs, peripheral lymph node TB, uncomplicated pleural effusions, and if there was intrathoracic lymph node TB, no airway obstruction. These patients were randomized to the control arm, which was the standard 6-month regimen that we're currently using, and the interventional arm, which was 4 months. So the same 2 months intensive phase, but the continuation phase is only 2 months. There was no difference between the two groups in terms of the clinical and demographic characteristics. And of note, the mean age of the children was at 3.5 years, 52% male. The study was done in South Africa, India, Uganda, and Zambia. So 88% of the participants were African. Only 11% were HIV positive. And you can see the mixture there in terms of the type of disease that they had. And 14% had bacteriological confirmation of MTB complex. So looking at the results, you can see that, in terms of the unfavorable outcomes, there was really no difference. TB recurrence, extension of treatment, restart of treatment, no difference between the two arms. And the forest plot really demonstrates the fact that the 4-month regimen was non-inferior to the standard 6-month regimen. The dotted line was the pre-specified non-inferiority margin of 6%. So what are some of the considerations in terms of the SHINE trial? 2/3 of pediatric TB is non-severe postbacillary disease. So these patients can now finally benefit from a shortened regimen. Of note, in the SHINE trial, they used the dose-optimized dispersible tablets, fixed drug combinations with INH, rifampicin, and PZA in those dose combinations. And even with the ethambutol, there was a dispersible tablet of ethambutol that was used. And then the continuation phase would also be in the dispersible tablet formulation. Now, this means that for consideration to use the 4-month regimen, every single patient would need a chest X-ray to actually evaluate whether they truly have non-severe disease. The patient would need to have a smear microscopy, because if they are smear microscopy positive, that suggests a huge bacillary load and they would be ineligible for the 4-month regimen. However, if the patient has only had the gene expect ultra, if the gene expect is negative, they qualify. If it's trace, they qualify. If it's positive, you would need to request the back end to get a semi-quantitative result, so that if it's very low or low positive, they still qualify. So our results are currently coming as a qualitative results of positive, negative, or trace. But that back end is available, so you need to request it. Of note as well that younger children were excluded. So in the SHINE trial, kids less than 3 months of age, patients with severe acute malnutrition, patients that were sick enough to require hospitalization, and patients that had received TB treatment within 2 years. So summarizing now the alternatives that you've got for drug-susceptible TB treatment is that you've got firstly the 4-month regimen from the SHINE trial, and that would be for patients that are eligible for it. The patients that are eligible for it are also, you can also give the 6-month regimen, because the SHINE regimen was not superior to the standard 6-month regimen. Alternatively, for those patients that are not eligible for the 4-month regimen, then you would use the 6-month regimen. For children that are over the age of 12 years, there's another study that has been published this year in the NEJM that has documented non-inferiority of a 4-month regimen. So highlighting once again that issue of different combinations. So this combination was using INH, The P is rifampicin, PZA, and moxiflox. And they were able to demonstrate that that 4-month regimen was non-inferior for even severe forms of pulmonary TB to the 6-month regimen. So that would be another option for that patient population. For extrapulmonary TB, so peripheral lymph node TB patients are eligible for the 4-month SHINE regimen. Alternatively, you can then use the standard 6-month regimen. And interestingly, in the SHINE trial, there was no difference in resolution for peripheral lymph node TB with 4 months of treatment versus 6 months of treatment. And we do know that TB lymphadenitis can take a very long time to respond to treatment. With all extrapulmonary TB, it's a 6-month regimen, and I think we still find that patients are being given longer regimens for 6-month regimen. It's not indicated, just the 6-month regimen is fine. The exceptions being TB meningitis and osteoarticular TB. So the long regimen for both of those is the same, which is the WHO recommended 2 months of intensive phase with 10 months of the continuation phase. The South African guidelines is slightly different, and that becomes the 7 months with a continuation phase. And as well as WHO now has also endorsed what has been used in South Africa since 1985, the intensive 6-month regimen for TB meningitis. So using ethionamide, which has got better CNS penetration. So not to forget that for TBM and for TB pericarditis and for large lymph nodes, and for all of these, you are really expecting that as you initiate the TB treatment, you get increased inflammation, and in confined spaces, you don't want increased airway obstruction, as well as swelling within a confined space. So then the adjuvant steroids are needed. So we're not quite done yet, and this is probably that first point, the most important part of this talk, that you then, having made the diagnosis and initiated treatment, then you need to assess for response to treatment. And patients that are on the correct treatment for TB respond. And that response, you expect to see it within 2 weeks. They start gaining weight, they become apyrexial, they improve their appetite. And if you are not getting that clinical response, then you should be evaluating for adherence to the TB therapy. You should be re-looking at your diagnosis, especially now that is the B, the bugs, especially when you've made a composite clinical reference diagnosis of the TB. Is this the right diagnosis? Is it perhaps a non-tuberculous mycobacterium? Is it another condition? Are you dealing with a paradoxical iris? Or in patients that are immunocompromised, is there completely another infection and you've missed the diagnosis of TB? As well as evaluating whether the patient is on correct treatment. So the dose that you prescribed, is it correct? Is that the same dose that was given by the pharmacy, as well as is that the same dose that's been given at home? Evaluate for drug-drug interactions, that's the D, and then as well as looking at whether is this possibly a drug-resistant TB. And in those patients that were smear positive or they had a high bacillary load, you would also have to evaluate for a bacteriological response. TB notification, we must all remember that we are part of the TB, national TB program. And that step of notification is key in terms of, certainly for kids, to go and find the source patient and start interrupting the transmission, giving TB prophylactic therapy to those patients that only have TB infection, as well as starting treatment early in those patients that have got TB disease. Drug-drug interactions, especially for patients that are on antiretroviral therapy, don't forget to boost. I mean, all of those regimens that Mo has just spoken about, they are dolutegravir based and as well as lopinavir ritonavir based. So they will require boosting with the TB treatment. Manage comorbidities. Perhaps the reason the patient is not responding is because there is an uncontrolled comorbidity. And as well as in patients with immunosuppression, then there could be very well even other infections that need to be managed. Nutritional support and monitoring for drug toxicity is not to be forgotten. So this is my last slide that, it's important to understand the limitations and strength of every single weapon in your TB arsenal, both diagnostic and therapeutic. And understanding these enables you to avoid the pitfalls and landmines of this TB diagnostic and therapeutic landscape. And you can walk a steady path on shaky ground. In future, there's going to be lots of different developments in the TB world. Look out for the TB prophylactic therapy guidelines. Probably within a month, they'll be disseminated. Our last TB guidelines for PEDS was 2013, and the overall guideline was 2014 in South Africa. So there should be new TB guidelines coming out soon, as well as there will be new TB guidelines for drug-resistant TB as well, even though the current ones are not so old, 2019. There are lots of trials in progress looking at optimized doses. So the OptiRIF study looking at higher doses of rifampicin, TBM kids also looking at a higher dose of rifampicin for TBM. And then the SHORE study also looking for TBM and just looking at trying to get that duration lower and just establishing which is the best combination and regimen for TBM. So this is my last slide. Thank you very much for your attention, and I am open to questions.
Nosisa, thanks for an excellent talk. Lots of useful information, practical guidance. That was great, thank you. We are almost at 10:30. There were a number of questions, some of which you addressed in your talk relating to urinary LAM, but I think there was maybe one outstanding one on the use of LAM testing in severe malnutrition. And then two questions which maybe you could address either in the break now or when you have a moment. One relating to the definition of a positive TB contact, and a similar question as to what's the definition of infectious TB, which I think is going to the same issue of how do you sort of define a contact in the case of children, because it's such an important part of making or suspecting a diagnosis. So if you could maybe just have a look at those if you have time. I think what we'll do then, if it's okay with everybody, is it's 10:28 on my clock now. We were due to have a quick comfort break of 10 minutes. So I think if we can have a break now until you can, don't disconnect, stay on the meeting, but just for people to get up, stretch their legs, have a comfort break. We'll be back at 10:40. So that's in about 11 minutes from now. And we'll start that session. Is that okay, Marty?
Yes, that's perfect. Thank you so much, James.
Okay, we'll see you all in about 10 minutes. Thank you.
Hi, everyone. I'm going to start talking and introduce myself, and thank you to the organizers for doing this. I think it's a fantastic initiative. And good morning from a relatively cool Pretoria this morning. My name is Nicolette, for those of you that don't know me. I work in Pretoria in infectious diseases, and I'm very pleased to be chairing this session that is going to focus on congenital infections. And we've got two fantastic speakers. So I'm going to give all of you a few more seconds to join, but I think in the meantime, I'm going to introduce our first speaker, Dr. Hafsah Tootla. Thank you, Dr. Tootla, for entertaining us and presenting this morning. So Hafsah studied at UCT and is a clinical microbiologist. And she currently works at Red Cross War Memorial Children's Hospital and is very enthusiastic about treating and looking after the children there as far as diagnostics are concerned. So thank you so much for joining us this morning. Hafsah is going to discuss congenital syphilis, the diagnosis and the management thereof. And I think you all agree that the last few months has been really challenging with the stock out of penicillin. And I think most of us are not really sure if we are doing our children a favor by trying to treat them without penicillin. But Hafsah is going to chat to us about that. Thank you, Hafsah. I'm going to put myself on mute and you've got the floor. Thank you.
Good morning, everyone, and thank you very much for the introduction and the invitation. Before I go into the technical details on congenital syphilis, I thought that I would just give you a little bit of information on the organism itself. My slides are not advancing. Let me see if that will work. Okay, there you are. Can you see that? Okay.
Yeah, it's good.
Perfect, thank you. So syphilis is caused by Treponema pallidum, subspecies pallidum. It's a spirochete. It's also known as the great imitator or imposter because of the wide variation in clinical presentation that patients can present with. So this includes adults and neonates and infants, ranging from asymptomatic to severe disease with multiple manifestations, or in between with one or two manifestations. It's quite a sneaky, devious stealth pathogen in that it lacks outer membrane proteins and lipopolysaccharides that are usually necessary to trigger the immune response in humans. So therefore, it's able to evade the immune system quite well, allowing efficient replication and dissemination of the organism within the human. There's quite a high burden of disease. It's estimated that there are around 6 million new cases of syphilis annually amongst adults, with the highest prevalence in Africa. It's also estimated that there's around 930,000 maternal infections, which result in 350,000 adverse outcomes annually. And this can range from stillbirths to neonatal deaths to preterm births and infected infants. An updated review of the epidemiology in 2018 suggested that there was a 3.5 to 6.5 prevalence in pregnant women in Africa. And looking at local data in South Africa from 2017, it was reported that there were new incident cases of 23,000 to 47,000 patients and adults, and this basically equated to a prevalence of 0.5 to 0.97% in the adult population. So when we look at the prevalence of syphilis in South Africa over the last 3 decades or so, you can see that the trends have really declined over the last 30 years, including in the antenatal clinic setting, which is reflected by the solid squares, the green solid squares. And this has mostly been attributed to screening and treatment at antenatal clinics and high-risk populations, also the introduction of the syndromic management of STIs and the availability of diagnostic tests, whether this has been increased access to lab-based tests, or where people don't have access to lab-based tests, the introduction of point-of-care tests. Despite this decrease over the years, there has been a signal from 2017 to 2020 of increasing, 2017 to 2021, of increasing cases of congenital syphilis reported in our surveillance system in South Africa. And this is reflected by the solid line where this is the number of cases that have been reported, as well as the solid bars, which are the number of RPR positive specimens in children less than 2 years of age, implying that there's increasing numbers of congenital syphilis. These trends are also seen in the US, where they've also reported increasing numbers of congenital syphilis, as well as increasing rates in the adult population. So this is alarming and quite concerning. So why is all of this important? It's because essentially congenital syphilis is entirely preventable and easily treatable. And if you treat it, you prevent serious morbidity and mortality in the infant. Transmissions are occur most commonly transplacentally, but you can also have transmission during delivery if the neonate comes into contact with infectious lesions in the mum. Untreated syphilis in the mother results in congenital syphilis, most commonly in primary and secondary syphilis with high rates reported, 60% to 90% respectively, as well as in early latent syphilis where the rates are around 40%, and in late latent syphilis, 10%. Disease severity in the infant will depend on the classification of disease in the mother, the RPR titer, and the gestational age when transmission occurred, with a higher risk the older the infant, the gestational age. Clinical features are broken down to early clinical features and late clinical features, and it's an arbitrary classification, and the cutoff is 2 years of age. The spectrum, as I mentioned, can vary from asymptomatic, with most patients actually being born asymptomatic, with symptoms only developing within the first 4 to 8 weeks of life. And then you can have a range of clinical presentations with severe infection at the end of the spectrum, resulting in stillbirth, neonatal death, where sometimes if the mom presents still in pregnancy, early enough in pregnancy, you may still find some of these features on ultrasound findings. So things like high drops may be seen on ultrasound. At birth, though, you would look for symptoms like desquamating rash, lymphadenopathy, hepatosplenomegaly, nasal discharge, which can be snuffles or rhinitis, jaundice, an abnormal CSF cell count or protein, pneumonitis, growth retardation, bone changes such as periosteitis and epiphysitis, anemia, and hydrops. Some of the late congenital findings, which we don't see anymore, this was usually seen in the pre-penicillin era, where infants were left untreated and they had long-term syphilis replication and dissemination, leading to these clinical findings. So we luckily don't see them anymore, but it's still useful to know, resulting in interstitial keratitis, Hutchinson's teeth, frontal bossing, and Sebaceans. So some of these pictures are quite old, and we won't encounter them hopefully anymore. The laboratory diagnosis of congenital syphilis mostly relies on serology, and that's because routine diagnostics like microscopy and culture are not helpful. Spirochetes are really too small and thin to be visualized using routine light microscopy. So to see spirochetes on fluid from nasal discharge or amniotic fluid, you need dark field microscopy or fluorescent microscopy. Dark field microscopy is only really available in the research setting, and fluorescent microscopy, there's been an issue with getting reagents for this, so it's not offered anymore. You will also unable to culture it on artificial media, and you need animal models using rabbits, and that is the gold standard for diagnosis, but obviously not very practical in the routine diagnostic laboratory. You can also use molecular tests like PCR, but also this is mostly limited to the research setting. Another important diagnostic is histology. So if you had an infant who was, or a neonate who was born where you suspected congenital syphilis, it's useful to look at the macroscopic features of the placenta. They will usually be large and pale, and also to send the placenta for histopathology, where you'd look for features of velitis, small gummas, and also visualization of the spirochetes using silver stains or immunohistochemistry staining. But I'm going to focus mostly on the serology, which is the mainstay of diagnosis of syphilis and congenital syphilis. So there are two main antibodies that we look for. They're treponemal antibodies and non-treponemal antibodies. The treponemal antibodies are antibodies that are specific to the organism Treponema pallidum. These usually remain positive for life in most cases, and they cannot differentiate current disease from past disease. Examples of these antibodies include FTA antibodies, so fluorescent treponemal antibodies, or the newer ELISA-based Treponema pallidum tests, where if you send your samples to the National Health Laboratory Service, that will be reported as TPAB. IgM antibodies against Treponema pallidum will appear first, followed by IgG antibodies, and this response typically happens 6 to 14 days after infection. IgM will eventually decline, but IgG, as I mentioned, usually remains positive for life, even with treatment. Looking at non-treponemal antibodies, they're non-specific tests, and they're essentially antibodies that are produced against material that has been released from dying host cells that have been infected by the spirochetes. They're usually directed against cardiolipin or phospholipids, and they tend to be positive a little bit later than your treponemal antibodies, so around about 10 to 15 days after infection. But typically the window period for detection is around 6 weeks. If you have someone who's untreated, their titers will peak at about 1 to 2 years after infection and then decrease slightly and remain positive even in late disease. After treatment, titers should decline fourfold, but this can take quite long and can be up to 6 months. Examples of non-treponemal serology include VDRL, which stands for Venereal Diseases Research Laboratory Antibodies, and RPR, which stands for Rapid Plasma Reagents. Important to note is that because these are non-specific antibodies, you can sometimes have biological false positive reactions, which can occur with febrile illness, pregnancy, connective tissue disorders, but it's important to monitor titers to differentiate these biological false positives from syphilis, where you would expect to see an increase in titers, and they usually have a low titer, so less than 1 in 8. That would be something to consider, that this may be a biological false positive. Advantages of non-treponemal tests is that they measure disease activity and can be used to monitor disease progression and disease response to treatment. So in our setting, it's mostly a manual test, and you can see at the top of the picture here that it's actually in reverse order, but this first well is a strong positive reaction where you can see agglutination from the antibody-antigen complex occurring. The middle picture is one where there's a mildly reactive reaction, and in the last picture there is no reaction. So the last one here is negative reaction, and the one on the other side is a strong positive reaction. So what do we mean when we say titers? Initially, what we'll start with is an undiluted sample in the first well, and then we'll make twofold dilutions, and then we'll test the sample with the reagent. And basically, the well with the last positive reaction is going to be your antibody titer. And the reason why we do this, as I mentioned, is to see if there's disease progression and also to see your response to treatment. So when we say there's a twofold increase, it's basically one serial dilution down. So if you look at example 1, if you go from a titer of 1 in 16 to 1 in 32, that's a twofold increase. Similarly, if you go down to example 2, a 4-fold increase is just 2 serial dilutions down. So you would go from a 1 in 8 titer to a 1 in 32 titer, and an 8-fold increase would be a 1 in 4 titer to a 1 in 32 titer. Essentially, we just multiplying so if we look at example number 3, a 1 in 4 titer, if we times it by 8, it'll give us 1 in 32. So that's how we interpret the titers. Some of you may have heard of the prozone effect, and this can also occur with these manual tests. And the reason this occurs is when you have a supersaturation of antibodies in your sample and not enough antigen in your test to form the antibody-antigen lattice that allows you to get this agglutination and visualization of a positive reaction. So to counteract that, we would have to do serial dilutions in the lab. And you'll see here in the undiluted specimen, there's a negative reaction. In the 1 in 2 specimen, there's a negative reaction, but we start seeing a positive reaction as we dilute in 1 in 4 and 1 in 8. And this actually is, we don't do this routinely, this dilution in the lab, unless the clinician has a strong indication of syphilis and gets an RPR result that's negative. Then it's an indication to call the lab and say that you think that you have a false negative RPR result. Could we please dilute down the specimen and see if we got the prozone effect? Luckily, this phenomenon doesn't happen regularly. It's reported to be about 2%, mostly in the HIV positive setting with secondary syphilis. So just to summarize the immune response, looking at the red and the green lines, those are the treponemal antibody responses, so IgM and IgG, increasing in the first few weeks and increasing earlier than the RPR and VDRL non-treponemal antibodies, which is indicated by the blue line. The IgM for the treponemal antibodies will peak and then eventually disappear, but the IgG will persist for life. The treponemal IgGs will persist for life. The non-treponemal IgM and IgG will remain high if the patient is untreated or has failed treatment or reinfection has occurred, and this indicates disease activity. If you have a patient who's treated, then your IgM and IgG for their non-treponemal antibodies will also decrease, but this can take quite a long time. And you can see that the decrease will happen more rapidly if you start off with a higher titer. But if you start off with a lower titer, the decrease can take quite a long time. This response will also be seen in the infant or the neonate with congenital syphilis, but what complicates the interpretation in this setting is that the maternal antibodies, the maternal IgG antibodies, both treponemal and non-treponemal, will be passed on via the placenta to the infant and will complicate the interpretation of serology. So when you're interpreting serology of the neonate or the infant, it needs to be done in conjunction with the maternal serology, and blood for this needs to be taken at the same time. You may have also heard of the different testing algorithms for syphilis serology, traditional versus the reverse algorithm. And essentially, the only difference is the order in which the syphilis serology has been tested. So with the traditional algorithm, they will typically do the non-treponemal antibody test first, followed by the treponemal antibody test. And the reverse occurs with the reverse algorithm, where we would test the treponemal antibody first, followed by the non-treponemal antibody. In our setting at the NHLS, we do the reverse algorithm, and the reason for this is multiple. Probably the most the main reason is that the treponemal antibody test is an automated system which allows us to do high volume samples with short turnaround times versus the manual non-treponemal test. The additional benefit is that you can pick up antibodies in earlier with primary syphilis. But it doesn't really matter which algorithm you use, and there is no recommendation that one is better than the other. It's just the point of the slide is just to show that you need to have both treponemal and non-treponemal antibodies to interpret syphilis serology. So with the diagnosis of congenital syphilis, early congenital syphilis, it will be those children who are less than 2 years of age who have a mother who had untreated or inadequately treated syphilis at delivery, regardless of the signs in the infant, or those infants or children who have non-treponemal reactive syphilis serology. So in our setting, this would be RPRs, and any of the following clinical features, radiological features, a positive VDRL test in CSF, because that shouldn't be from, you shouldn't have that from passive transmission of placental immunoglobulins from the mother, as well as an IgM antibody test in the serum, because IgM is not transferred from the mother, only IgG is. The diagnosis is also supported by RPR titers in the infant that's 4-fold higher than that of the mother, suggesting that the infant is mounting an immune response and has syphilis, as well as those infants where the non-treponemal test persists, the titers persist or increase after birth when you do serial tests. We shouldn't really be using treponemal antibody tests for diagnosis, but sometimes you may encounter a situation where you will see an infant that presents after 15 months of age. And by this period, the maternal immunoglobulin should not be present. So in this setting, if you have a treponemal antibody test that's positive, that's indicative of congenital syphilis, as well as IgM anytime in the infant, because you shouldn't have that from maternal transfer. So Nicolette mentioned the treatment of syphilis and shortages of penicillin. And I think the reason why she brought that up was because penicillin is actually the only recommended treatment for congenital syphilis. It's dependent on whether or not the patient is symptomatic or asymptomatic. In symptomatic neonates, we will give parenteral penicillin, and please note that the frequency of administration is different depending on the age of life of the neonate. So in the first 7 days of life, it should be given every 12 hours. In the period 7 days of life to 10 to 14 days of life, it's given 8 hourly, and after 10 or 14 days, it's given every 6 hourly. In asymptomatic individuals, you can give IM benzathine penicillin. And then if you have a shortage of penicillin, the literature is really, really scarce on what alternatives are available. And you can give alternatives like ceftriaxone or amoxicillin given with probenecide, but research is limited in this setting, and it's basically comes down to case reports showing successful responses using those antibiotics, but these case reports are limited to under 20 cases or so. Azithromycin is not recommended due to resistance being described, and also issues with failure. Other alternatives are really not recommended. So if we do have penicillin shortages, we need to contact the pharmacy and try and preserve that stock for congenital syphilis, which we usually do when we encounter scenarios like that. So in other scenarios, so the scenarios that I've described where we're looking at syphilis serology and we've got positive IgMs and high titers and untreated mothers, those are the cases that are more likely to have congenital syphilis. We do have scenarios where there are gray zones where it will be less likely or unlikely. So the less likely scenario is where you've got a neonate who has a normal physical examination, but your non-treponemal serology, so your RPR titer is equal or less than fourfold of the maternal titer at delivery, but you had a mother who was treated during pregnancy, the treatment was appropriate and initiated more than 30 days before delivery, and the mother didn't have any evidence of relapse or reinfection. In these settings, you may not have maternal titers to show improvement or good treatment response. And some authors or some experts will recommend giving benzathine penicillin in this scenario. And the reason for that is because follow-up of these patients, you may not get the patient back, and you don't know whether or not the mom has been reinfected. So this mostly covers that group of moms who may get treatment, but the partner may not be treated and the mom may get reinfected. So the thinking is that it's safer to rather give the infant the dose of benzathine penicillin in the unlikely scenario that they don't represent. If you have a patient where you think that they are going to represent and you can follow up titers, then you can do the watch and wait approach, but it's not really recommended. The unlikely syphilis scenario is when you have a mom who had a positive RPR prior to pregnancy, or so a positive RPR or TPAB prior to pregnancy, was treated prior to pregnancy, and you followed up the mom's RPR titers in pregnancy and it remained low or stable during pregnancy, suggesting that this was a past infection. This is the only scenario where you don't have to treat the baby and can watch and wait. So follow up for any individual or any neonate or infant with positive non-treponemal tests needs to be done every 2 to 3 months, and you need to follow them up until they become non-reactive. RPR titers basically should decrease and be non-reactive by 6 months of age. And if this does not happen, you need to reevaluate and include a CSF analysis in that, because you may need to retreat these infants with a 10-day course of parenteral penicillin G. Neonates who have a negative RPR at birth and whose mothers were seroreactive at delivery should be retested at 3 months, because this may be a birth or an early syphilitic infection in the mother, where the syphilis response, the antibody response, was negative due to incubating congenital syphilis at the time of birth. So those patients need to be followed up. As I mentioned previously, treponemal tests should not be used to evaluate treatment response, because these results are qualitative and passive transfer of maternal IgG can persist for up to 15 months of age. So just to end off, screening and prevention is incredibly important in this setting. Essentially, WHO is trying to promote the elimination of mother-to-child transmission, and in order to do this, we need to do early screening and treat early. So our recommendations in South Africa are to screen moms at first-time visits, as well as at 32 weeks gestational age. In brackets, I've put their delivery and high-risk moms. So these are moms in which you know that the partner hasn't been treated, or the mom's engaging in high-risk behavior where there's a chance of contracting syphilis after the 32-week period. Also important to note is that lesions in the neonates are highly infectious. So these neonates need to be handled with gloves until at least 24 hours on treatment. Don't forget to notify these patients. It's category 2 notifiable medical condition. Don't forget to screen and treat partners. And also, if they are younger infants or younger siblings, don't forget about them, because they may have latent syphilis as well. Thanks very much.
Thank you so much, Hafsah. That was a really informative talk. I really liked your explanation of the titers and the different scenarios. I think that is really, really helpful for us as pediatricians. I think all of us are going to probably have questions and actually more concerns, isn't it, about the stock out of penicillin, because it really isn't something that we as pediatricians can do a lot about. But I think following up patients that have not been on penicillin is really urgently needed, that we know what we are doing if we don't have penicillin. In the interest of time, Hafsah, please have a look at the questions and the chats. Please, if everybody has got more questions and chats, please continue. Hafsah is available and will gladly answer it for you in the chat box. And thank you again for this very informative talk. I'm going to move on to the next speaker. Theunis, Prof Avenant, is a pediatric infectious diseases specialist. He's also my boss. He doesn't like me saying that, but head of department at Kalafong, University of Pretoria. And he's very enthusiastic about logical and critical thinking. If you look at patients, if you try and get to differential diagnosis and then making a diagnosis. So he is going to actually discuss something I think it's really important for us when we talk to students to look beyond acronyms and really look at specific congenital infections. Thank you, Theunis. I look forward to listening to you.
Thank you, Nicolette. I only have about 6 or 8 or 12 organisms to discuss as opposed to the other ones. So I'll try and make up time. So I think I'm in a privileged position. So what happened in 1971? We can see here what the fashion was like, what the cars were like, the movies, actually color TV, the Jacksons. What else happened in 1971? There was a meeting of the American Pediatric Society in Atlantic City, and the NAMIAS actually had the abstract comes from that conference on the torch complex, and this is where it was first described in children with similar presentations of Toxoplasma rubella, cytomegalovirus, and herpes. Like some of the things on the previous slide, this just went all crazy, and the acronyms started getting little extras until we get to cheap torches. I can't even know what cheap torches stand for or everything. So if we need to think logically about this, in 1971, this was a great car, but this is how the car looks now in 2022, and then there are different ways of looking at congenital infections now. Let me get straight to the point and not dwell on it too long. Torch serology. Torch is not an etiological agent, and screening is expensive and has a poor diagnostic yield. And there are many more pathogens we need to consider. Think of indications. We'll speak about SGA now and the wrong interpretation. So the bottom line is torch titer should never be used as a single test in a neonate to rule out congenital infection, and it's considered outdated. Now, people will say, you've been saying this for 10 years and blah, 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 and we know the story. Should we use it for IUGR? I mean, there are many studies that show that it's ineffective. And if you just think of a definition of small for gestational age, I mean, we'll need to test 1 in every 10 babies. So it makes very little sense. So now coming back, is it still a problem? Are people still doing torch screening in neonates? This is a survey coming from the USA, the 553 participants in the survey, and these are neonatologists, and this is how they diagnosed congenital infections. So the torch titer in about 57% being done as a screen, even after all the literature, etc., is available. Even more concerning non-specific tests like just a total IgG and a total IgM. So clearly there's still space for a lecture like this to try and get rid of this practice. So what are the diagnostic principles when we look at congenital infections? I think the main thing is we're not starting with a blank screen. There are things that we can consider. The clinical symptoms, which are not the same in all the congenital infections. What's the epidemiology? What's happening to the mum? What was screening done for the mum and for infections? Has she been anywhere? What is a sexual behavior like? And then we should do targeted testing for specific pathogens in well-defined circumstances. Just stepping back a little bit. So we need to just distinguish between congenital infection that's acquired in utero, and organisms cross the placenta. It may be ascending fairly late in pregnancy, so not everything is crossing the placenta. Perinatal infection, mostly around delivery, may be ascending. Neonatal infections during the first 28 days of life. So which organisms can cause infections in the neonate? And I mean, there's a long list, and this is by all means not everything. I thought it good to just quickly look at the 6 ones marked in orange, and then some of the other ones were discussed and some are completely out of the scope of this lecture. So awareness of the prominent features of each of these things will make it, of these infections will actually make it much easier to make a more targeted diagnosis. So I've on purpose decided not to start with Toxoplasma or T4 torch, so I've decided on varicella. So if you look at varicella, the transmission risk is approximately 2% before 20 weeks. If it's very early, the transmission is actually a little bit less, or quite a bit less. And if you look at the findings, I mean, the intrauterine growth restriction, but the typical scarring lesions, we'll see that on the next slide, and ocular defects, which may be many, the limb abnormalities, often hyperplasia, segmental abnormalities, and then all the central nervous system abnormalities. And there is an overlap with other infections, I do agree. But if you've got congenital varicella syndrome, the mortality is quite high in the first few months of life. In the children who were infected a little bit later in pregnancy, they actually may not have that many signs at birth, but they may develop herpes zoster in the first 4 years of life. So the antenatal diagnosis, you can do PCR testing on fetal blood or amniotic fluid. We'll talk a little bit on fetal blood later. For varicella zoster, and you can do ultrasonography. You can see this child's got a hyperplastic limb. He also had a small colon and then eventually actually died. Postnatally, how do we make the diagnosis? You can see the scarring skin lesions in the dermatomal distributions there. We need to have a history or proof of a maternal varicella, and then the presence of these abnormalities that are compatible. And then we need to find evidence of intrauterine infection. So you can do IgM antibodies in cord blood. If you've got tissue that you can look for, you can do varicella zoster DNA in the newborn. And if a varicella zoster IgG persists, it will be a diagnostic. And then if you find zoster early in infancy, it is also indicative. Toxoplasma, and I'm not going to run through all the clinical features and clinical signs of each of these diseases, otherwise we'll still be here tomorrow, but I've put them onto the slides just for people to have a look at later if I want to see what goes where. I think with Toxoplasma, most important that 70 to 90% of newborns will have no manifestation on examination. So if you've got a suspicion, you need to go and do other investigations as well. We'll discuss them later. The clinical features, and I've divided them into systemic signs, neurological signs, ocular signs, and lab signs, or lab abnormalities. The ocular signs are quite prominent. I think we all know about the calcifications, and we know about the growth retardation, the sepsis-like picture. So you can go and look at those. The prenatal diagnosis of Toxoplasma always scared the hell out of medical students, and if you go and look at the antibody interpretation, you'll see that it may be quite complex and a lot of repeat testing may be necessary to actually make the diagnosis. But something that is available now has actually made it very easy in a sense that you can do a PCR for toxoplasma on the amniotic fluid, and the specificity and positive predictor value is actually 100% with a negative predictor value of 98. So I think in the end, this is where we will be going to make a definite diagnosis of intrauterine toxoplasma infection. What other tests do we need to do on all patients whom we suspect, those ones who we're not sure and those ones who we're sure? Everybody should have a lumbar puncture. You can do a PCR on the CSF, neuroimaging, a scan or an MRI, definite eye examination, hearing evaluation, and then serology. So the diagnosis in the newborn, so if you find the DNA in the CSF, that's definite. You need to have IgM or IgA. So just be careful when you do the IgM and the IgA during the first few days of life. There may be a placental leak and you may have false positives. If you've got initial negative or positive serology and you don't have clinical abnormalities, you may need to repeat it. And the main thing is your IgG, that if a mum's positive, will be positive at birth, the titers must go down. So if these titers remain high, that's actually a very definite diagnosis of toxoplasma. If you find the clinical findings, but you don't have a serology, do all the other testings, do the PCR and repeat your serological testing. And then you can see if none of these are positive and your IgG declines, you have an excluded congenital infection. Cytomegalovirus. I think the transmission is most 30 to 35% when you've got your primary infection in the mum just before or during pregnancy. If you have non-primary infections or a different strain, the risk is quite lower. And the earlier the infections are, the poorer the outcomes are. This is a very common disease, and if you look at the overall birth prevalence, 0.64 in some, it may go up higher than 1% in some populations. So it's quite a common disease. So I thought it wise to just go and show what happens to these children. If you take 1,000 infants with congenital CMV infection, about 100 of them will be symptomatic, and they'll have the symptoms and signs that we teach you: microcephaly, thrombocytopenia, hepatosplenomegaly, sensorineural hearing loss, chorioretinitis. And then you can see in this group of symptomatic patients, which are the long-term sequelae, and especially the neurodevelopmental impairment, the hearing loss, the eye problems, so they're very severe. But if you go and look then at the 900 asymptomatic cases of congenital CMV, what will happen to them? So at birth, they will not have any visible signs. That's asymptomatic. But if you go and test them, 81 to 117 of them will have hearing loss. And if you look in the long term, then on these 900 asymptomatic cases at birth, you'll see that the hearing loss in about 90 to 135 and up to 27 of them may have neurodevelopmental impairment. So how do we make the diagnosis of congenital cytomegalovirus? And I think the most important thing is you need to identify the virus before age 3 weeks. The problem is that after that, you will have difficulty distinguishing between postnatal or perinatal acquired infections. Both the European and the American guidelines will use saliva PCR as the first test or the main test. If a child's breastfeeding, you need to collect urine to actually confirm it. You can also do blood PCR. If you look at the bottom there, the IgM assays are unfortunately very non-specific, and you cannot easily rely on them to make the diagnosis, and you get a lot of false positives. Also, it becomes very difficult to make the diagnosis of congenital cytomegalovirus outside the perinatal period. Next one would be herpes. So the message here is that intrauterine herpes simplex virus infection is very rare. What needs to happen, you need to have your primary herpes simplex virus infection or viremia during pregnancy. You may also have an ascending infection that's usually late in pregnancy. Most of the herpes simplex that we see would be perinatal infection. And I'm not going to discuss that. I mean, we all know the picture of a child with disseminated herpes, etc., etc. And then remember that children can also acquire herpes postnatally from nursing staff, from mothers and other people. So in this slide, you see the skin lesions of a child who was infected in utero with herpes simplex. So what happens in utero? You can have placental infarcts, eye drops, and then fetal demise if you've got a severe intrauterine herpes simplex infection. And the typical triad of things that are described with skin vesicles or ulcerations or scarring, with eye damage, with severe central nervous system manifestations. But this only occurs in a third of patients, so you should remain with a high index of suspicion. If you've got late intrauterine infection due to ascending infection, this is very typical like the perinatal infections, and it may be really mild, but it may also go like scarring, but it may also be disseminated disease with all the organ system involved and death. So that can be quite a varied presentation. If we now go and look at the diagnosis of herpes simplex, I think we've moved on from viral culture to PCR. And the bottom line is actually just go and swab and take samples from as many places as you can. And you will be able to find the herpes simplex virus in there to make the diagnosis. If we go and look at rubella, if you've got early infection, you've got 80 to 85% of defects if a child is infected very early in pregnancy. The earlier, the more the structural defects, cardiac eye defects, especially if a mum's infection is before 8 weeks, the hearing loss a bit later. And once you pass 20 weeks, it's very unlikely that you will have the severe congenital defects. So I've just listed the abnormalities as early manifestations and late manifestations. So early, we spoke about central nervous system, sensory neural hearing loss, congenital heart disease, eye disease. But I think in the late manifestation, things that we tend to forget would be the endocrine disorders like diabetes or thyroid disorders. Remember that these children may have T-cell defects. And I think the very important thing is remember the prolonged viral shedding. If you've got a child like this in your ward with other children, mums, staff there, these viruses can be shed for, I want to say, many months up to actually usually not longer than 2 years, but quite a long period of time. So the lab diagnosis, again, with PCR, it's actually quite easy if you can get the rubella RNA from the nasopharyngeal swab blood sample, because I've just said these children excrete quite a lot of viruses. I mean, rubella-specific IgM, yes, and again, if the IgG does not disappear. The lab diagnosis of congenital rubella becomes a bit more difficult after 1 year of age, because then you don't know what is postnatal and what is prenatal, but I think the clinical picture may help. And then the last virus that I want to discuss is parvovirus. Okay, if you think, again, this is limited to the first half of pregnancy. If fetal death, if it's early in the pregnancy up to 6.3% of affected pregnancies. Then you can also get transient effusions, and I think that this is because of direct pleural or myocardial inflammation, and they actually resolve before term, and then you get the typical fetal hydrops because the B12 is cytotoxic to fetal red cell precursors, and if a mum's infected early, it gets worse. So how do we diagnose this? Again, you can go to the amniotic fluid antenatally and do a polymerase chain reaction. You can also try and get blood for B12 IgM, but remember that there is a 1% fetal loss rate if you go and try and get blood from the baby. In the neonatal infection, can look at the IgM, but you can also detect B12 DNA in neonatal blood. There are unfortunately the possibility of false negatives, even in severe infections. So I'm going to close here. I think I'm not going to repeat the fact that we shouldn't be doing torch screening in the neonate. I hope that I've convinced you. Thank you very much.
Thank you, Theunis, for that very insightful discussion. And I think these are 6 very important congenital infections to consider. I've always been in agreement with Theunis that torches is out of date, and I see it just celebrated its 50th birthday. And in the words of my teenage children, that's really old, mummy. So I'm going to repeat that to, I think, all my registrars that ask for torch screening. I shall repeat my children's words. So there's just, it's really just a discussion from the lab point of view. So I'm not sure if, Theunis, you're going to ask it, but they say the lab isn't offering parvovirus testing in KwaZulu-Natal. Maybe the reasons behind that, maybe someone of the lab can help with that. I think just following that on that question, Theunis, maybe you can just give your ideas of the lab actually still offering torch screening. Should they not actually phone the clinician and ask more information, do more targeted screening than just sort of putting out a torch? What are your thoughts behind that?
I think they should remove it from the laboratory request forms to make it really easy. I think in the neonatal period, it's got no place. I think the fight will have to be with our obstetric colleagues, which may argue it may still or may not have a role. But I think even in obstetrics, the targeted testing, the amniocentesis, and all of these things are taking over. And I'm not sure we should be doing any broad-based test anymore. I mean, we've got enough modalities to do much more targeted testing even in the pregnant patient. So I think we should just remove it from all requisition forms.
Fantastic, thank you. So any further comments, questions to both of our speakers, to Hafsah or Theunis, please continue in the chat and the Q&As. They are going to stick around and answer it. Thank you so much again for both of these fantastic speakers. I'm going to close this session and then hand over to very capable Marty. Thank you so much for your attention.
Thank you so much, Nicolette. Much appreciated. So we're now going to go over to the bacterial infection section, and we'll be talking about typhoid and Staphylococcus infections. And that's something that we've in KZN really seen a lot of the last year. So maybe I'm a little bit biased being excited about this session. So I am going to introduce Prof Helena Rabie. And what I've learned from her is she really doesn't like bias, because there's very little to find about her on the internet. In terms of bias, but she's a well-respected researcher. She is a pediatric infectious disease specialist, currently working at Tygerberg Hospital, and she's also still a fantastic generalist, and that makes her so well-respected by all her pediatric colleagues. So thank you so much, Helena. Handing over to you now.
Thank you, Marty, for inviting me. I'm old, so I don't go much to the social media and the internet, clearly. Thank you for asking me to talk about this very important topic. So, as always, we start with a case, and this is a child that we saw recently, referred from one of our peripheral hospitals, sick for about a month. Biggest complaints: weak, losing weight, not having energy, arthralgia, vague history of tuberculosis exposure. At the local hospital, she received some antibiotic, about 3 days of ceftriaxone, and then because they didn't think that there was really a bacterial infection, as per good AMS principles, they actually stopped the antibiotic. And you can see here on your right, the results, basically low sodium, lymphopenia, nondescript anemia with normocytosis, slightly low platelet count, and some raised inflammatory markers. And at the local hospital, a blood culture was actually done and it was negative. And when we saw her, she just looked very chronically unwell. And she had vague abdominal pain and discomfort. There was a history of some loose stools, a murmur without cardiac failure. And when you examine her abdomen, she was a little bit uncomfortable when you examined it, but there was no clear peritonitis. And then we noted splenomegaly. And when we found these things, we were a little bit suspicious of a specific organism, which was in fact typhoid. And so what we requested, and this is actually very, very important if we consider utility of blood culture, we asked that us as pediatricians make sure that we make a good volume blood culture in this patient. And we were indeed able to identify this organism, Salmonella typhi, from the blood culture. And what were clues to her having typhoid? The sort of longer history of being unwell with a subacute and a chronic course, the vague abdominal symptoms. She was clearly unwell, but not septic looking. And then, of course, geospacing. And one of the clues here was that we had recently, actually from the same street that she lived in. And that's why it's so important to always find, follow Prof Blumberg's guidance on who are you, where do you stay, where do you play, what do you do, where have you been? And geospacing, knowing that actually looking back, we saw a patient from the same street as this child with typhoid, made us suspect it. And just another issue around geospacing is, of course, knowing what's happening around you in the world. And here we also know that there were massive outbreaks of typhoid in our neighbor Zimbabwe. And we also know that this is, in fact, one of the questions that we always ask in people from Zimbabwe: have you been home recently, or has anybody in your house been home recently, when we start worrying about diseases like typhoid. So what is typhoid? I'm so happy that Dr. Tootla is also here. She can correct me if I'm making a mistake, but there are many, many Salmonella organisms, and they are broadly classified into Salmonella enterica and Salmonella bongoi. And then the enterica, there are multiple subspecies. And the one that typhoid falls under is Salmonella enterica, subspecies enterica. The other subspecies are not unimportant. They can also cause disease. And again, going back to ID principles, do you have pets? Increasingly, we see people having reptiles, snakes, lizards as pets, and they can definitely cause illness in people that have those kinds of exposure. The Salmonella enterica, subspecies enterica, is then divided into typhoidal and non-typhoidal Salmonella, and these both can cause disease. I just want to, let me just go one slide back. So the non-typhoidal Salmonella also can cause intestinal disease and invasive disease. And the diphoidal Salmonella basically are the two groups, as you can see here. And again, just my rudimentary drawing of how this organism looks. It's part of the Enterobacteriaceae, and so they are gram-negative bacilli. They have long flagellae and somatic and surface antigens. And this is indeed how the laboratory works towards identifying the specific organism that we are dealing with. Though the non-typhoidal Salmonella species are actually quite important and deserving of some review on their own, as we are also possibly seeing some increases in invasive non-typhoidal Salmonella, what I really want to focus on today is a typhoidal Salmonella. And you can see here that when we're talking about typhoidal Salmonella, we are talking about both Salmonella typhi as well as the paratyphi A, B, and C. And together they are called enteric fever. And this illness has a long history. It was in 1829 that Pierre Louis actually first used the word typhoid to describe detailed post-mortem findings and indeed describing the ulceration of the Bayer patches. And you can see here a progress through history where William Budd identified the contagious nature of the illness and linked it to sewers. And organism was first identified in the abdominal lymph nodes in 1880. In 1884, Robert Koch indeed found the Vibrio cholera or the comma virus. And we know that the comma virus or Vibrio cholera also linked to waterborne disease. And really looking at vaccination right from the late 19th, early 20th century. And the first antibiotics were used in 1948. And indeed, 2 years later, there was the first resistant cases reported. And one tends to think that, you know, it was self-evident that these, from the identification of the link to sewers and that the comma virus and the link to cholera, that this would have been self-evident that it is in drinking water, but there were other theories about how it spreads, and people were throwing shade on each other. And von Plettenau famously said that the one and only drinking water faith does not hold water. And talking through the history of this, and I know it's not a history talk, but I think we learned many lessons from this. There were many outbreaks of typhoid, and this is quite a famous one in which Robert Koch actually testified about the explosive nature of the epidemic and using the epidemiological principles of who got the illness, where were they in relation to each other, and indeed linking it to the specific pipe water supply, in this case where over 3,000 people got typhoid and 8% of people died. And you can see even after this, there were still people writing, let's liquidate the drinking water theories. Very interesting. The history of some individuals being able to spread the disease without showing signs and symptoms is also famous in medical history, where we have the curious case of the typhoid woman, Mary Malone, who was then subsequently called Typhoid Mary. And there's a very interesting history to read here on how George A. Stoper, who wrote many papers on her, actually stalked her, and she was forced to give specimens. And subsequent to her, 400 people were identified as carriers, but nobody else were incarcerated. So it's also some learning points on ethics. This gram-negative bacillus can survive for several months in water, and it can grow at various temperatures. And as I've mentioned, and we all know already, it is a waterborne disease, and you can get it through ingestion of food and water. There are some pseudogenes encoding for inactivations by stop codons. And so this is actually one of the reasons that we think it only infects humans. And there are also genes encoding for specific pathogenicity factors. Salmonella typhi and Salmonella paratyphi A, B, and C cause very similar clinical diseases. And although there are some theories earlier that Salmonella typhi had a more serious or more severe clinical progress, many papers actually equate the disease severity with each other, apart from suggesting that paratyphoid fever may have a slightly shorter incubation time. You can see that the global epidemiology, how many cases there are, and that in sub-Saharan Africa, we have about 12.1% of all the global cases. And indeed, when we're thinking about typhoid, we do tend to think of the Indian subcontinent and Pakistan and India specifically, but here you can see the cases in thousands and the incidents, and I've just in red highlighted sub-Saharan Africa, showing that we actually have significant caseload for typhoidal or for enteric fever. Age really matters quite a lot. And the only infectious disease that adults are less likely to die, more likely to die of than children is, of course, old age. So you can see here that age matters, and it matters here when we're looking at disease onset. And you can see that the majority of disease is described in children, and this is also true for sub-Saharan Africa. If we look at causes of sepsis, typhoid and paratyphoid are the 6 most important causes of sepsis. And I'm highlighting here at the bottom, the non-typhoidal Salmonella species are also very important. In South Africa, we are actually endemic for Salmonella typhi. And you can see here the cases are of about 0.1 cases per 100,000 population of culture-confirmed typhoid fever. You may see there was a spike here in 2005 when there was actually an epidemic of waterborne typhoid in the Delmas area. The provinces that actually mostly report typhoid is the Western Cape and Gauteng. And a majority of cases are coming from those provinces. It may well be that there is a difference here, not necessarily in typhoid, but rather also looking at access to laboratory infrastructure and culture. So it is not necessarily reflecting very specific areas of concern. And we know, as Martin mentioned, that there are many cases reported also in other provinces and of particular concern also in KwaZulu-Natal. HIV did not increase the incidence of typhoid in South Africa, but it may have changed the severity, and we know that the severity of the disease is actually what predicts the mortality. Recently, there's been clusters of cases, and you can see here 3 clusters of cases in the Western Cape, in Cape Town, the Winelands, and in the Garden Routes, as also a cluster of cases in the Dr. Kenneth Gunda municipality. And these cases were in fact investigated by the NICD, and they were found to be unlikely linked to drinking water, but rather to untreated cases in the community and reservoirs. And we are all very concerned about drinking water, as we know that, in April, there was a damning report on the quality of drinking water. And you can see here how we are actually looking at various municipalities at critical risk, and boil water notices have been issued in some municipalities. But as to date, there is no evidence that any cases are specifically linked to contaminated municipal water. So how do we worry, or when do we know that we're seeing an increase in cases? I think you need many friends, and the 2 friends that I'm highlighting here in green is one of my colleagues, adult colleagues, Dr. Yankee Taljaard, and we also have our friend in the laboratory, Dr. Reddy, and often as clinicians we work in silos, but it's nice to actually remember that other people are also seeing things clinically and also seeing things in the laboratory. And what we need to start doing is work with our friends at NICD and also at the local communicable diseases areas where we really need to always try to be in touch with each other and have crosstalk so that we can know whether we are seeing indeed an increase in cases. And for instance, when I actually notified one of the cases of typhoid to this lady, Charlene Lawrence, who is working in Cape Town with communicable diseases, she actually told me, yes, we know that there are other cases in that community as well. So knowing what is going on is always going to help us identify cases. Moving away from this topic, just my rudimentary sketch trying to illustrate the disease pathogenesis of typhoid. You actually need quite a few organisms, many more than, for instance, Shigella, to become unwell. So you need about 10 to the 3 to 10 to the 4 organisms, and low gastric pH actually kills the organism. So obviously you can already see which patients might be at risk. In the incubation period, there's internalization of the organisms into the Peyer's patches and into the mesenteric nodes, and after which time you get your first bacteremia. And both these bacteremia cycles, there are actually very few organisms in the blood. So that's why it's so important that you make sure that you get a high quality blood culture. When you actually, the organism then goes to the spleen, the bone marrow, and the liver, and then there's the second bacteremia, and it can go all over the body, specifically also infecting the gallbladder, and again, infecting the Peyer's patches. And this is actually a very important component because a lot of mortality is driven by necrosis and perforation. The organism can get shed for several weeks and in 4% of people for more than a year. The classic presentation is the rising stepwise fever. There can be chills, but rigors is uncommon. The relative bradycardia or the pulse temperature dissociation is something that is very commonly described in patients with typhoid. There are some data to also suggest that it might be less common than we think in children, but certainly it is a classically described feature. In the second week, we have high-grade fever, and often, and this is also a clinical clue, there is no source of infections. Rose spots are reported to be very common or very uncommon, and I think may be very difficult to detect in patients with dark skin. Other symptoms include the flu-like symptoms, the abdominal discomfort, the dry cough, and myalgia. And then in the third week, we see the hepatosplenomegaly, secondary bacteremia and peritonitis, which is often the cause of death. Here you can see a little bit of how we can break down some of the signs and symptoms according to age. And in the adults is where they typically describe this issue of constipation rather than diarrhea. But we know in children, diarrhea is a much more common symptom than constipations. Meningitis is actually uncommon, and seizure is usually because of febrile seizures. As I mentioned, the intestinal perforation and the secondary bacteremia that we see with that is a very important cause of death, and it's more important, more commonly seen in older children and in adults. In the laboratory, we will frequently find anemia, leukopenia, or leukocytosis. Thrombocytopenia is actually reported to be uncommon. You can also see liver enzymes, and it can raised, and it can actually be difficult to distinguish from viral hepatitis. And as I mentioned, even in patients with seizures, there is often not meningitis, and there's mostly just a mild pleocytosis. In adults and in some children, they also report these neuropsychiatric symptoms and a typical stare. I've just again highlighted here that how common anemia is, leukopenia and leukocytosis, and in children leukocytosis is more common than leukopenia, and then how common the hepatitis is. Risk factors for infection is low gastric acid, and for severe infection, HIV, glucocorticoid therapy, altered phagocyte function, malaria, and sickle cell anemia. And certainly in early report from South Africa, actually, that young age was a risk factor for severe disease and high mortality. And this is a paper from 1990 where they describe close to 600 South African children from KwaZulu-Natal presenting with typhoid. And you can see here how high the fever was. Nearly 60% had a fever of more than 40 degrees. And only one patient had a rose spot. Interestingly here, when they also reported the time to become fever-free was up to 7 days. And in this paper, children were treated with amoxicillin. The differential diagnosis should be wide, but I want to highlight a recent disease that we're seeing in children, and we've also been confronted with adding this mysterious MSC to our differential diagnosis. And this is a case series from the PIDJ where they've actually reporting salmonella and bacterial enteritis mimicking MSC. And we've certainly also seen children being referred with MSC where we've actually diagnosed them with bacterial enteritis. So it is just something to keep in the back of your mind that MSC can look like anything and anything can also look like MSC. The most important way to diagnose it is, of course, to culture. And I'm sure we're all aware that bone marrow culture is the most sensitive diagnostic modality. But blood culture, which is much more available, is what we usually need to use. Stool culture can be positive in about 30 to 40%. And you can sometimes find salmonella in patients where you didn't suspect it. On stool culture, and in those cases you should actually obviously interpret it in line with the clinical features. Urine culture can also be positive, and then in some places they do duodenum content where they do a string test. You can see that when we're looking at blood culture versus stool and bone versus bone marrow culture, blood culture is less likely to be positive than bone marrow culture and has a lower sensitivity when you compare it with bone marrow culture. Currently, these are our case definitions, and I want to highlight the suspected case because I think this is where the problem lies with enteric fever is how do you suspect it? And you can see that it's any person with fever for at least 3 out of 7 consecutive days, symptoms compatible with enteric fever. So that is why it can be a very non-specific suspected case. And so it can make it quite difficult to narrow things down. Confirmed cases, of course, is those that you've got a case from a clinical sample, and probable cases should only be used during an outbreak where you have epidemiological link to confirmed cases in people with clinically compatible symptoms. I don't want to say too much about other testing. These tests are not routinely used, and though they are increasingly developing rapid antibody diagnostic tests, most of them are not available in routine care and is not as good as culture. And when you're looking at old papers, you'll often see the Vidal test. So the Vidal test is the test where they're using antibodies to the surface and H antigens, and these are actually region specific and must be determined for individual geographic areas. Carriage is the convalescent carrier is a person who you've treated and there's still evidence of shedding, and this can happen from 1 to 12 months after finishing the appropriate course. And the definitive carrier is somebody who sheds for more than 12 months after the course treatment. And you can see here that the risk factor for carriage is gallstones, and in urine, renal stones, and also bilharzia. Here's the treatment, and you can see that the treatment really looks at how complicated or uncomplicated the patient's course of disease is. Ciprofloxacin is the drug of choice for the majority of complicated and uncomplicated cases. And the duration changes whether you think the patient has complicated or uncomplicated disease. As complicated disease requires longer treatment. And you can see also ceftriaxone, azithromycin, and in the case of drug-resistant bacteria, other forms of treatment might be needed. And drug resistance is a real concern. And as I've mentioned, drug resistance was first reported already 2 years after the initial cases, but quinolone resistant typhoid is well known in South Africa, with case reports going right back to 2003. And you can also see here globally there's actually a spread, and they've documented XDR typhoid fever cases in many countries, and often imported cases from the Indian subcontinent and Pakistan. When we're looking at adjunctive treatment, apart from supportive care, there is some data to support steroids for patients with severe infection, and those would be patients in shock, coma, and obtundant. And the treatment that is studied is dexamethasone. As I've mentioned, in the with antibiotic, the mortality is low and or less. And it is mostly now related to resistant infection because those patients access therapy late, and perforation, where you actually have a secondary bacterial infections happening. Once you've treated the patient, you need to check if they become a carrier. And so you need to do stool 1 week after you've completed antibiotics, and the first one, and then subsequently every 48 hours for 3 stools. And if you originally had a positive urine culture, you should repeat urine with stools. And if any of these cultures are positive, you need to treat for 1 month and do monthly stool samples. And if those remain positive, obviously you need to investigate for the cause. All contacts should also be managed, and we're looking here at household members, caregivers of cases, and people who may have eaten the implicated food, water, and beverages, if it's in the same household. You should have a line list and interview these patients or these persons, and there are some standard documentation available to do this. You need to also collect stool, and if you cannot get stool, you can use a rectal swab, and these should go for culture. And if obviously positive, those patients also need to be followed up for antibiotic treatment. And it's very important to educate all contacts on enteric fever, on transmission prevention, and how to recognize symptoms and how to seek medical help when this occurs. With regards vaccination, there are a number of vaccines available. But in South Africa, only the unconjugated bipolysaccharide vaccine is available, and you can use this in children from 2 years older. It's a single dose of intramuscular vaccine, protects for around 3 years. It's not effective against paratyphoid enteric fever. And one would definitely recommend this for people traveling. And then increasingly now, we are looking at many clinical trials where they're looking at typhoid conjugate vaccine. And this is just one trial that was recently done in Malawian children, where they randomized children from 9 months into a polysaccharide vaccine, and the control was meningococcal vaccine. The outcome was blood culture confirmed cases, and you can see here significant protection provided by the vaccine against typhoid in these children. Typhoid looks a little bit like the pink meanie, very beautiful jellyfish that you can see at the aquarium. I don't know if there are any questions. I'd be happy to try to answer them.
Thank you so much, Helena. That was such a wonderful overview. We are running a little bit behind on schedule, so people please bear with us because there's so many fantastic discussions. So I know that Helena has been great in the chat, so I'm going to ask her to please answer the questions in the chat if that's possible. And I'm going to go over and introduce Prof Nicolette du Plessis. So she doesn't need a lot of introduction because she's very well known to most of us. She's a registered pediatric infectious disease specialist and an associate professor and head of the Pediatric Infectious Disease Division of the Department of Pediatrics at the University of Pretoria. And she's also the current president of FITSA. So thank you so much, Nicolette. She's going to talk to us about disseminated Staphylococcus infections and talk more about the bloodstream infections. Thank you so much. Over to you.
Thanks. Thank you for that kind introduction, Marty, and thank you again for Marty, James, and Lucille. I am still looking at the pink mini, Helena. If you stop sharing your pretty picture, and then I can share.
I have actually paused. Sorry, let me just see what is going on. Oh my goodness. Is it stopped now?
It's stopped. Thank you so much. Thank you. Thank you. All right. So let me start by sharing mine. All right. So looking at disseminated staph infections in children, and the focus of today really, Marty and the EXCO asked me to really look at who is at risk, the source control and antibiotic therapy. And in the interest of time, because I'm really interested to listen to Dr. Rollinson, that will be talking just after this lecture, I'm going to answer all these questions for you and then really whiz through my slides, and everybody is obviously more than welcome to get a copy if I was maybe too quick for any of you. So are there risks for both superficial and invasive staph infections? The answer is yes. Of course, we know about nasal carriage, and about 30% of us have at any one time have got a likelihood of carrying staph, and particularly also MRSA as healthcare workers in our noses. But apart from that being a risk for transmission and for invasive disease, there are specific risk profiles for both superficial and invasive staph infections. Source control, very important. Once you are dealing with a patient with a staph infection, we've said this so many times, but the offending foreign body or pus should be drained, replaced, or removed. Antibiotics are not going to sort out pus or any foreign bodies that are part of the problem. And then there are considerations for source control, infection prevention and control, considerations for decolonization in patients that are up for quite big and invasive surgeries. And then, of course, part of source control or just managing your patient is in invasive staphs. We always would ask for echocardiogram. And then antibiotic therapy, again, you need to understand the bug that you're working with. And by that I mean, is it a sensitive staph where Cloxa is still the main antibiotic? People don't get fancy and try and throw something else on a sensitive staph. Cloxa still remains the mainstay. Obviously, if you've got mixed infections, skin infections, something like amoxiclav can be used. In resistant staphs, depending on which one you are working with. So here, as all the RD specialists has said, please have a good relationship with your lab because in your hospital-acquired MRSAs, obviously we all know vancomycin or linezolid. In community-acquired resistant staphs, a little bit of a different antibiogram, and you can get away with things like Bactrim, Clinda, Dapsin, daptomycin, if you know about inducibility of resistance, with or without antibiotics such as rifampicin. You can have decisions on topical or parental antibiotics, antibiotics, topical obviously for mild skin infections, and then remember the toxin-related staphs where clindamycin is a good option. All right, so I've given you the whole talk, but let me just quickly then go through it and introduce you to your staff. You've got support staff, you've got administrative staff, and unfortunately in the hospital, you've also got resistant staff, which is called MRSA. So if you deal with staphs, remember there are many kinds, and this is where you need your friendly microbiologist and you need samples. Go send them to the lab and get the MICs, because you deal with methicillin-sensitive Staph aureus. You can deal with resistant Staph aureus that are resistant to methicillin, but also vanco-susceptible. And this is obviously the MRSA that you want. Unfortunately, we've come to a situation with overuse of antibiotics. You all know this, where our resistant MRSAs are now also becoming what people fondly call VISAs, or vanco-intermediate Staph aureus susceptibility, and you really need to up your vanco dose, increase the area under the curve, give prolonged infusions, and really come up with a sort of plan to manage this. And then, of course, the headache of many ID and lab personnel is, I see the Americans are calling it VERSAS, but I would rather just say VRSA or vanco-resistant Staph aureus, where the vanco MICs in these staph isolates is more or equal to 16, and you're really in a little bit of a trouble. So depending on which type of staph you're dealing with and where it is going to determine your treatment. And just a little bit of micro 101, remember that MRSA is transferred on the carrier we call SCC-MEC, and SCC-MEC then encodes MEC-A, and that encodes, that actually puts in our staphs penicillin binding protein 2A, and 2A does not like our beta-lactams, and so that's why we coin it MRSA. That's not the end of the story. Traditionally, we then said, well, did you acquire it in a healthcare setting or did you acquire it in a community? But these are no longer two distinct entities. Both can spread in any other situation. And so why is it important to know whether it's a community-acquired or hospital-acquired MRSA? Well, there's a little bit of treatment tweaks that you can do with these two resistant staphs. So you can try and get a criteria or come up with a sort of idea. Are you maybe dealing with community-acquired MRSAs or not? And some of the ideas is to look at the time of isolation. Was the infection considered to be inside your hospitals? And what is your hospital MRSA resistant patterns? What is the host profile risk? Is this an athlete or a dorm student? Or is it a diabetic, 60 plus diabetic with diabetic foot that's got a CVP in situ? Of course, you will look at your susceptibility patterns. And then in molecular characteristics, look at the specific type of cassette that the staph is carrying, or the SCC-MEC type, at PFGE types, and the presence of Pantin, Valentine, leukocidin. And I'm sure only the ID specialists and the microbiologists are now enthusiastic about these words. But anyway, this can lead to actually very clear decisions if you know what you're dealing with, about what would work. And this is just an example of the differences between a community-acquired and a hospital-acquired MRSA. And why is it important? Because I don't want you to overuse vanco if you're dealing with a community-acquired MRSA, and you can use other less toxic and more accessible drugs that won't lead to vanco resistance in the future. Okay, so there are some antibiotic choices for pediatric community-acquired MRSA, and then I've just given you some idea of the Nicolette and the vancomycin. In the essence of time, I'm not going to spend a lot of time on exactly how you should be giving it. There are some guidelines here. I just want to spend a little bit of time on vancomycin and say, really, in the essence of antimicrobial stewardship and preserving our drugs, I want to implore on you today that if you use drugs such as vancomycin, to really do therapeutic drug monitoring, and do it with your lab and with your pharmacist, and really tweak your targeted levels, and also then your dosing, so that you can get the maximum benefit out of vancomycin as quickly as possible, get the maximum benefit for your patient without the unintended consequences of further resistance with prolonged low doses. That's not going to be efficient. So in vanco, certainly drug monitoring is something that I would implore on all of you if you can. All right, so then where do we start? Well, we start with the carriage, and the most important risk for invasive infection is obviously having a staph in your nose. And most research articles will quote around 30% of us can carry Staph aureus, and it increases a little bit in preschool ages up to about 50% of the toddlers. And if you carry MRSA, colonization can be prolonged. They've had recorded cases of up to 40 months of MRSA colonization. And of course, if the little ones then have additional, or not even little ones, any of us have got additional respiratory tract infections, that will also increase the risk of spread. And I'm talking about us, meaning all of us listening here, because healthcare workers obviously are one of the risk groups that can carry MRSA because of our work environment. And so if you have it on your hands and those mobile phones, I don't have to talk about that, do I? Or either mother to infant transmission, airborne, especially if you've got associated respiratory tract infection, or if you're looking for gold in those nares, any nose picking can lead to possibility of transmission, and that can either be obviously in a nosocomial setting and in a community setting. Okay, and staph is one of those organisms that can almost cause anything. So this is by no means a complete list, but just to highlight, it can be toxin-driven, such as food poisoning or toxic shock syndrome. It could be superficial in your skin and soft tissue infections. And then, of course, we are always quite concerned about invasive staph infections, such as meningitis, biofilm-associated infection, sepsis, mastitis in breastfeeding mothers, septicemia, UTIs, osteomyelitis, and always worried about endocarditis. That's by my introduction, I said we would always advise to do an echo if you've got invasive staph infection. And again, Dr. Rollinson is going to concentrate on osteomyelitis. So just quickly going through to staph skin infections, it can present in many ways. And in our population, we work with neonates and with older children. Remember, most of the skin and soft tissue infection in newborns will be, or neonates will be due to staph. We also get some group B strips that occasionally could cause cellulitis, but group A's are less common in our neonates than in our bigger children. And here, if you are worried, it doesn't just look like this picture where it's a common pustulosis. If you follow this diagram and your infant has got fever, hypothermia, is not looking well, is not feeding well, and is irritable, you need to go and look further and probably hospitalize this newborn and consider not just topical, but also intravenous therapy. So again, here highlighting what does the patient look like in front of you. Just quickly rehashing some of our skin infections, impetigo, carbuncle, erysipelas, which is one of the most serious skin infections, and of course, the big old abscess. When should you use oral antibiotics, not just topical, if the child is systemically ill, if there's underlying medical problems, multiple sites of infections, a young little one, if the lesions are big in older children, 5 centimeters or more, and in the younger guys, 4 or more centimeters. Very important, if you have staph lesions on the face, hand, or perineum, you need to add oral antibiotics at least, and if there are implanted devices. And then you can follow these type of guidelines. This is from Up to Date. I think most of our junior doctors like accessing Up to Date. Keep in mind that this is not South African, this is American guidelines, but giving you some indication on what is my patient, what is the staph that I'm dealing with, where am I finding it, and then sort of targeting your therapy. I've got more of these, and like I said, in the interest of time, please ask me. I'm happy to share them with you. So getting to the risk factors for invasive staph infections, Almost most children with invasive staph infections are normal, but some of the risk factors, if you have a sick child with foreign body, such as a catheter, a graft, or CSF shunts, very important. If the child had preceding influenza or measles, they can have a high risk of developing, especially a staph pneumonia, underlying malignancy, prem babies, immunodeficient and immunocompromised hosts, and our diabetics. All right, important notes about invasive staph infections. All staph isolates from normal sterile sites should have MICs, please, guys. And invasive infections such as osteomyelitis and arthritis, pneumonia, abscesses, endocarditis, and again, consider doing echoes with patients on invasive diseases, bacteremias, central nervous system infections, and toxic shock syndrome. Try and culture the staphs and try and get a MIC, because that is going to lead to your management principles. Remove the potential foci of infection and choose your anti-staph antibiotics. Like I said, a sensitive staph, you can't just go vanco and say, now I've covered everything. A sensitive staph is still sensitive to cloxa and responds better to cloxa therapy than vanco. So it's important to know your MICs and choose your anti-staph cover wisely. The duration of therapy, that's always a question. Well, that depends upon the site. For example, topical mupirocin for 3 to 5 days if you've got a small topical lesion, antibiotics for 7 to 10 days with your more complicated skin and soft tissue infections. And then with invasive disease, often we would quote anything from at least 2 weeks of IV, in more severe, at least 4 weeks. Remember, in the past, people would say 4 to 6 weeks, but I think the thinking now is at least 4 weeks in your severe infections. And then the more ill your patient, the more serious your staph infections, such as endocarditis and central nervous system infection, parental therapy is recommended for the entire course. And then oral therapy may be used for a portion of the course in patients with other types of infection. And this is where this hybrid going of starting with IV for about 10 to 14 days and completing your course of oral antibiotics. So just a question here that I've received, eradication for OPD. So GP phoned me and said they see a lot of healthy children in the practice with recurrent staph skin infections, and he's comfortable giving them whatever he wants to give them every time, but how can we reduce the risk, and can he try and eradicate it? Well, the answer is, I'm sure you can. You can have a strategy of hygiene education, nasal, we have Bactroban or Pyrrhicin, and bath washes with chlorhexidine or diluted bleach. Remember, that dries out the skin horribly, so please lather them with cream after that. But in a sort of general setting, decolonization is going to be temporary. And if you don't target the whole household, he's highly likely to just obtain staph again from his peers or his family. So not very, very successful. But certainly in inpatients, staph carriage eradication is instrumental for infection control and prevention. And remember that we don't just carry it in our nares. There are extranasal staph aureus colonization, and it's more common than previously believed. So the usual decolonization strategies with mupirocin only are probably insufficient if you really want to help a patient before, if they are colonized with MRSA and they are up for big surgery, probably a combination. And here is an example, for example, of a colonization using nasal decolonization and topical decolonization, and some guidelines even use oral antibiotics. So I hope I'm in time. I hope I've given Dr. Rollinson plenty of time to discuss osteomyelitis, and please send your Q&As and I'll continue to chat in the chat box. Thank you so much for your time. Thank you, Marty.
Thank you, Nicolette, and thanks for rushing through that. I think you can catch your breath now. I'm going to go straight into introducing Dr. Rollinson. So like Helena, I don't think Dr. Rollinson likes very long introductions and bios. So I'm just going to say, if you chat to his colleagues, they will tell you that he is one of the best orthopedic doctors ever to work in the public sector. He's devoted his life to patients at Ngwelezan Hospital in KZN, and I've co-managed some of our staff's patients with him, so I am very much looking forward to his presentation. Thank you so much, Dr. Rollinson.
Right, good morning, Marty. So I'm just trying to get this onto the full screen, and
so you can just go to slideshow.
Into slideshow, yeah, I prefer to keep it. Sorry, let me just start again with that.
That's it.
I'll go into slideshow, yeah. Thanks very much for the pleasure of talking to you guys. It's not very often I get to talk to pediatricians, but it's a great pleasure. I'll just run through the rough background to this. And this is an overview of the talk. And this talk is sort of precipitated by Marty because, as she said, we've shared quite a number of difficult cases recently, very, very sick children in the PEDS ICU, generally with multifocal osteomyelitis and septic joints. And one or two of these children were so sick, we really didn't think they were going to survive, but fortunately they did. Just run through the extent of the problem. I'm being based at Ngwelezan Hospital, which is in northern KZN, and we have a catchment population of roughly 2.2 million, with a few extras from Swaziland and Mozambique. And we see approximately 80 new cases of bone and joint sepsis every year. And late presentation to the orthopedic department is the absolute rule almost, it's a routine. And because of late presentation, nearly all these kids require surgical drainage. Having said that, because of that, about 40% of these children will go on to get a complicated result, i.e. chronicity, long-term issues. And we have the unenviable honor of publishing the worst results for septic care ever published in the world, with 66% having a complicated outcome. Why do we get such poor results? It's because really of late presentation. We published a paper a few years ago in the SAMJ, and we were trying to find out why we were getting such late presenting cases. And we collected a year's worth of bone and joint sepsis in children under the age of 15, and we collected 80 cases. We had a follow-up clinic where we followed up these children for at least 3 months, and then we categorized the children at follow-up into uncomplicated, with children who made a full recovery, with no further signs of sequestrum or chronicity of infection, both clinically or radiologically. And the other alternative was the complicated cases. This was a 40-odd% with signs of residual infection and other issues, either clinical or radiological. Here you can see a couple of long-term examples of this, with extensive osteomyelitis of the humeral shaft, with sequestrum here falling out, and here a devastating case of bilateral femoral head necrosis, secondary to septic arthritis, probably in infancy. This was a a view of our caseload, fairly widespread distribution of cases, pretty standard, with, as usual, a large number of cases centered around the hip joint and the knee joint especially. Our results showed of our 80-odd cases, there were 50 cases of osteomyelitis, and of these 50 cases, 18 of these were fairly early cases with sepsis confined to the medullary cavity and being confirmed by operation and drilling the bone and getting a positive culture, or there were cases that were treated clinically on clinical suspicion of osteomyelitis just with IV antibiotics. There were very few of these. 24% of the long bone osteomyelitis had very advanced osteomyelitis with circumferential stripping of the periosteum, which basically means that the underlying cortical bone, as you can see here with a large sequestrum, that's going to die in all probability. And this is especially the case in the tibia, as is shown in this example, where about a quarter of the osteomyelitis that we saw in the tibia were pantibial and very extensive. This is our results of surgical drainage, where we looked at the time to surgical drainage, which was necessary in nearly all the cases because of their advanced nature of presentation to us. And as you can see here, with the osteomyelitis cases, a few were made it to theatre within the magic 5 days, but most were drained much, much later, some extremely late. As you can see with the hip sepsis cases in blue, there were 20 hip sepsis cases in this series, and only 4 made it to theatre within the magic 5 days to achieve surgical decompression and source control. When we looked at the osteomyelitis group in particular, we found that, and we looked at the initial presentation and diagnosis presentation, only about a quarter were correctly diagnosed at first presentation. More than a quarter, probably about a third, were diagnosed as trauma, because these were children presenting usually with a trauma history, which may be true or it may be a made-up history, because the children are trying to explain their problem, or the mother and father are trying to explain the child's problem. So a large proportion presented as trauma and were sent away with a bandage and some Panado and reassurance that it would all get better in time. A few, another about a third, were also diagnosed as cellulitis. And at least these children did receive their antibiotics, but they did not get their surgical drainage, which the vast majority of them needed at that stage. Mercer Rang, he's one of the doyens of pediatric orthopedics, describes cellulitis in children as the diagnosis of the naive. And I teach my interns and students that cellulitis does not exist in children. It's always osteomyelitis. When you say that, there's no always and no nevers in medicine. And there are 1 or 2 exceptions to that rule about cellulitis. One is the chubby toddler who presents usually with a fever, a swollen limb, but invariably some skin changes. And these are certainly worth a trial of 24, 48 hours of IV antibiotics, and they will settle it for a cellulitis. And it does exist in this sort of particular age group. The other child that we see with a cellulitis is a child with a swollen knee, often with a skin abrasion preceding it. And these children then go on, have their cellulitis. But having said that, a lot of them have a prepatellar bursitis, also full of pus. And a lot of these will actually still need surgical drainage. When we looked at the a rough statistical analysis of these cases and their presentations. We looked at a lot of socioeconomic factors, and what we found was the usual things that we would perceive as to why patients aren't presenting, such as a delay, such as a level of deprivation, distance to a clinic, and maternal education. They did not correlate with their delay to initial presentation. The frequently incriminator traditional healer visit didn't also not statistically hold up as a significant delay to presentation to a Western health care worker, such as a district hospital doctor, a GP, or a clinic nurse. Just run through a little bit about the pathoanatomy. My initial teaching in the UK about osteomyelitis, where we hardly ever saw it, was that it arose from the upper airways, from a sore throat or middle ear infection. That's just not the case, I think, in South Africa and probably in Africa at large, where I think vast majority of cases arise from skin infections. In this part of the world, in northern KZN, we have the most delightful winters. We're running at about 26 degrees today, but we also have the most incredibly hot and humid summers. And there's a lot of skin sepsis around in the kids, with infected mosquito bites and scabies also very prevalent. Also, a lot of these kids in rural and semi-rural areas have some degree of malnutrition and probably some degree of impaired general immunity, which sets the scene for potentially for getting a serious skin infection leading to bacteremia. When that bacteremia occurs, the bugs preferentially settle in the metaphyseal area of the bone and form a small abscess here. This is an area that's somewhat immunocompromised in terms of immunosurveillance, and the pressure in the small abscess builds up, and the pus then just leaks through the very, very thin, very porous cortex, and then starts to push under the periosteum, lifting the periosteum. The periosteum is tough in children. It doesn't breach or break easily, but what it does do is it lifts off. And as the pus lifts off, it strips the periosteum both longitudinally down the bone and also circumferentially. And when it does that, it basically starts to devitalize the cortex. Hence, we go on to sequela of chronic osteomyelitis and sequestra. In septic arthritis, the spread is probably bacteremic and just going directly into a joint, into the synovium and into the joint. But in some areas, there's a sort of indirect spread from the underlying metaphysis. So this could be a hip joint, and in the hip joint, the metaphysis, the capsule of the hip joint encompasses the metaphysis. So when we get an osteomyelitis in the proximal femur just under the growth plate, then as pressure builds up, instead of stripping the periosteum, because there isn't periosteum there, it basically goes in straight into the joint. So that's how one of the reasons why we see so much sepsis in the hip joint. And there are certain other areas, anatomical areas in the body, such as the proximal humerus, distal fibula, where this the capsule is around the base of the neck, so that the sepsis from the bone spreads directly into the joint. The other thing to note with a septic joint is that infants under the age of roughly 12 months, 18 months have vascular channels that cross from the metaphysis into the epiphysis. And so this becomes a route of sepsis, spreading from the metaphysis through the vascular channels, through the normally avascular growth plate. As I say, in these small children, this growth plate has vascular channels crossing it. They close around about the age of 12 months, and it spreads into the epiphysis and then from there into the joint. So that's one of the reasons why in small children we see a lot more septic arthritis. Marty particularly asked me to talk about, well, who is at risk for osteomyelitis, and really I think any malnourished, underprivileged child, certainly in our area, is at risk. And the biggest problem then is that they are at high risk of being misdiagnosed. Other at-risk factors are, you're probably well aware of, prematurity, low birth weight, immunocompromisation in terms of diabetes, etc. HIV hasn't made such a big impact in terms of numbers of kids with HIV, usually on treatment, do get osteomyelitis and septic joints. But in my experience, the number isn't great. But what we have seen in the last few years is we've seen adults coming in with recurrence of their osteomyelitis. This is an osteomyelitis that they had in childhood. It's been quiescent for the last 20 years or so. And then as they become HIV positive and their immunity falls, then the osteomyelitis reactivates. And we see that quite commonly in orthopedics. There are three types of presentation of these children. One is the neonate and the infant. And these classically will often present with a pseudo palsy, a child just not moving an arm or a leg. If it's an arm, it's usually a shoulder sepsis. If it's a leg, it's usually a hip joint sepsis. And X-ray in these children can be very helpful, even at an early stage. The standard child presents with a painful swollen limb, and the one that you as pediatricians are seeing occasionally is a very, very sick child presenting with pneumonia, multifocal bone and joint sepsis, frequently with a hip joint sepsis as well. Infant presentation. So this would be a child, as I said, not moving a limb. But one of the features of these infants is they're often not very sick. They're often apyrexial, and they're just off their feeds, for instance. And not infrequently, the limb problem, the pseudopalsy, is attributed to a birth palsy. Easy to ask the mother, in fact, was the arm moving at birth? Yes. Is it not moving now? No. Well, in that case, it's a new problem, not a birth palsy. Often a hip sepsis is picked up by mum realizing that the child just isn't comfortable when they're changing a nappy. But as I mentioned before, these children are often not that sick. Mentioned about X-rays in this group, and the X-ray in this particular case, this is a hip sepsis, and it does show a joint space widening. We'll look at that a little bit more detail later. The standard presentation is a sick child, usually peaking about the age of 6 to 7 years, with a swollen, painful limb. Sometimes, possibly up to literature tells us about 30% of children will have trauma, significant trauma a few days before, but often I think the trauma history is made up by the family or the child to explain their painful leg. And these children are often quite obviously toxic, often pyrexial. That's if the temperature is taken. And the problem with these children is that once they give this trauma history, they get their X-ray, they have a swollen limb. If they're not noted to be pyrexial at this stage, then they're often perceived to have some sort of soft tissue sprain, and were sent home with a bandage and a panado and reassurance. It takes roughly at least 7 to 10 days for an X-ray to show significant changes of osteomyelitis. And so when these children first present within the first few days with a normal X-ray, they are frequently misdiagnosed. The third presentation, like I said, is one that you're familiar with, is this very, very sick, toxic child, usually presenting to pediatrics because of the usually coexistent pneumonia, and often sepsis in many other systems. We've seen endocarditis with pericardial effusion. We've seen liver abscesses in these children. And from the orthopedic side, they often have multiple sites of bone and joint sepsis, and frequently a hip joint is involved as well. They will often then require, nearly all will require surgical drainage. They're difficult diagnoses to make to find out all the sites of sepsis, and often you will drain one area and then a couple of days later it's pretty obvious that another area needs draining, which wasn't evident 2 days earlier. Just running through the investigations, this is really a clinical diagnosis. Imaging and blood tests support the clinical diagnosis, but it's in the majority of children, it's a fairly straightforward clinical diagnosis. So list of blood tests that we take there. Blood cultures, we always seem to forget in orthopedics, but we do our best, we try. And CRP find particularly helpful. Rises very quickly, and it's invariably in these osteomyelitis cases, it's well over 200 in most of these cases, and it's very useful for follow-up as well to monitor the child.
Dr.
Investigation.
Sorry for interrupting. Can I give you a 2-3 minute warning because we are just a little bit over time?
Right,
Okay.
I'll speed up then.
Thank you so much.
X-rays, osteomyelitis, as I mentioned before, there's nothing to see on the initial X-ray except soft tissue swelling. This is a child that had osteomyelitis involving the whole femoral shaft with a septic hip, a septic knee, and lost 90% of his femoral shaft. This is a child that from a few years ago that had an intraosseous line with advanced changes here, but these changes are not evident in the first 10 years. I've mentioned this already about joint space widening in the smaller children. This is evident usually within 24 to 48 hours. Just continuing with various other modalities of investigation, ultrasound extremely useful in the hip joint. We see a bulging capsule, you can see it here. This capsule should be parallel to the metaphysis in the head. And it's something we do almost routinely, and quite a number of my MOs can do ultrasound. Contrasted CT is the other workhorse modality that we use for imaging these children. It's fairly readily available. Contrast helps, and it's especially useful when we're looking at the hip and the pelvis and also the spine. And here you can see abscesses forming in the iliacus muscle, the psoas muscle, and also some swelling in the gluteal muscles outside the pelvis. It's also extremely useful for follow-up. This is a child that we drained, one of our children from Queen Nandi that we did in the last few months, where we drained the hip, and then a few days later the child wasn't settling, and we can see there's extensive collections around the proximal femur, which needed further drainage. MRI is regarded in the first world setting as the gold standard, with or without contrast. It picks up osteomyelitis very early, bone changes very early. Here you can see a subperiosteal collection developing. You can define the extent of the disease. And here there's a septic hip with fluid in the hip joint. but there are so many limitations to its effective use. It's only available in a few hospitals. You probably need a GA for most of the kids, and it only looks at one particular limb. It's much the same with bone scans. It's been, to a great extent, been replaced by MRI anyway. But again, a lot of limitations to bone scans and availability, etc. Chest X-ray, you won't forget the chest X-ray, but the orthopedic surgeons frequently do. And these sick children, we need to do cardiac assessment with a cardiac ultrasound. A lot of them have pericardial effusion and endocarditis. This is our standard, this is our results from a few years ago, bacteriology. Staph aureus predominates, a lot of no growths. These no growths are from either kids previously treated with antibiotics or from septic joints, where we see a lot of no growths in all the world literature. Our antibiotic policy, based on Prof Hoffman's work from Red Cross Hospital, high dose cloxacillin, usually for a few days, 3 or 4 days post-operatively, followed by flucloxacillin. Remember, the sick kids, we probably ought to add gram-negative cover as well, and the smaller children under the age of 24 months have gram-negative infections as well as staph, so we need to cover those. Change once we've got the antibiotic profile from the cultures, blood cultures, and from pus. And we usually treat for about 4 weeks with oral management. Surgery is obviously important to drain any abscesses, as Prof Duplessis just mentioned. It's usually not difficult surgery. The difficulty is getting these sick children to theatre with anaesthetic concerns, senior anaesthetist to be involved. And we need to drain this pus, certainly under pressure, such as in a hip joint, as quickly and urgently as possible. Often the osteomyelitis is extensive. We need to drain multiple drainage portals. Often in a pantibial osteomyelitis, we'll make 4 small incisions and drain the whole length of the tibia. When we do a joint, we routinely take a gene expert and a synovial biopsy just to exclude the odd case of TB, which is said to can be manifest as an acute osteo. Further management really involves close clinical assessment, and especially in these sick children, we often find a further focus of infection a few days later. CRP useful to monitor your progress, and as I said, further surgery is often required. Just about to finish now. This was a couple of cases of osteomyelitis. This is a pantibial osteomyelitis case where the whole of the most of the tibial shaft sequestrated out. We pulled it out at operation. You can see the bone gap left. After cleaning up this cavity, sterilizing with antibiotics, etc., we putting a fibula strut graft, stabilized it with an X-fix, and this is a picture about a year or 2 later showing the graft consolidating, the fibula now becoming a tibia. So when we see these children with pantibial osteomyelitis, I know I'm going to be seeing these kids for the next 2 or 3 years with lots of problems. This is our final case. This is a 10-year-old boy who had problems. He had a PUO, managed at a district hospital for 2 years until they took an X-ray of his pelvis, which by this stage showed advanced osteomyelitic changes in both proximal femurs. The right hip had dislocated, and he then came to us 2 months later and had a barrage of antibiotics. A closed reduction of his hip, the head, which was by this stage avascular, just fell off. We took the head out and then stuffed the femoral neck into the acetabulum, held it in place with a spica for a number of months. And this is a child, we last saw him a couple of months post-op in his spica. He was then actually lost to follow-up, but he's a child that's obviously not going to do well and not going to walk terribly well. final picture, this is one of our children that we treated at Queen Nandi who was so sick with advanced osteomyelitis of the tibia and the hind foot and the ankle. And just to reiterate, the bone and joint infection is common, it's easily treated, it's curable, but you get devastatingly bad results when it's misdiagnosed and incorrectly managed. Thank you for your attention.
Thank you so much, Dr. Rollinson, for that. And I am going to ask you to please post your questions in the chats, and hopefully Dr. Rollinson will be able to stick around and answer some. We are now going to our final session, and I'm going to hand over to James to do the introductions.
Okay, brilliant, thanks. We continue with fantastic talks, and we are running a few minutes late, but please do stay to get the full benefit. So session 5 will be focusing on a bit of a mixed bag of things: tropical infections, then adenovirus and the various syndromes, and then some pearls, pointers, and takeaways from Prof Lucille Blumberg again. The first talk will be given by Dr. Julia Dabrowski, who has an interesting background of having worked a bit in child health, a bit in family medicine, internal medicine, back to family medicine. And she works in a rural setting, currently in private practice in Hoedspruit in Limpopo, I understand, but also spent some time as the doctor at Skokuza in the Kruger National Park. And she's going to speak to us about tropical skin infections. So thanks very much, Julia, and we look forward to hearing from you. If I can ask Dr. Rollinson just to unshare his slides. And then Julia, you can try and share your slides, please.
Thanks. Okay, hi, thanks so much for allowing me to present today. My talk is going to be quite quick and not too academic, but hopefully the pictures and the images will help to make it memorable. So I've been asked to do a few tropical skin infections, and those that we do see quite commonly in the Lowveld area, and we see in practice quite often. So I've focused on 3 of those. So just starting with tick bite fever, which you'll all be very familiar with. It's common in South Africa, caused by rickettsia infections, which are gram-negative bacteria, whose life cycle involves an arthropod, and in this case, a tick vector, and a vertebrate host. So mammals are the principal reservoir, and humans become just an incidental host. So clinically, we don't know how many cases there are because it varies so much to subclinical infections, mild infections, and then obviously very severe and fatal infections. And the 2 rickettsias that cause infection in South Africa is the Rickettsia connori and Rickettsia africa. So interestingly, Rickettsia connori are seen in the dog and kennel ticks, and then subsequently those infections will be more in the peri-urban and peri-domestic environment and areas, whereas Rickettsia africa is more in the cattle and game ticks, so more in the rural areas. Rickettsia connori tends to be a bit more of a severe infection and tends to cause more of that maculopapular rash, vasculitic rash than Rickettsia africa. So following the tick bite, there's a direct inoculation of the rickettsia into the blood vessels, and then the bacteria penetrates the vascular endothelial cells, and the pathology is that of a multi-organ vasculitis. So you have pro-inflammatory cytokines that then cause the fever and increase vascular permeability, and this results in the maculopapular rash with those non-blanching petechiae. And just to remember that maculopapular rash often will also involve the palms and the soles of the feet and hands. So we're looking at an incubation time from about 5 to 7 days. Fever, malaise, a headache, which is generally very severe, and body aches. And then the typical eschar, which is about a 0.5 centimeter to 1 centimeter black necrotic spot with an inflamed, sort of an inflammatory area around. So obviously, working in the Lowveld, we're always looking for these escars. It's a common infection that we see, and they can be hidden very often. So to remember just to look in the skin folds, in the between the toes, in the scalp, in the groin, and often palpating for lymphadenopathy will point you in the direction of where to find a possible escar, because the lymph nodes are inflamed and tender. So about 3 days later then, especially in the Canori cases, you can get that maculopapular rash. Diagnostically, it's normally a clinical diagnosis, looking at the triad of fever, rash, and the escar, and then obviously with the headache and everything else, and that's enough to initiate treatment. If lab investigations are required, then the PCR of that escar is the best. Serology can be done, but it's often negative initially, and you need serial serology in order to show the rising titers. The VL Felix used to be done, and it's not really, it shouldn't be done anymore. It's apparently not specific or sensitive enough. So looking at treatment, doxycycline is definitely the treatment of choice and used easily and extensively in adults. And in those children under 8 or pregnant women, it's still sort of recommended to try and use doxycycline for a day or 2 before moving to a macrolide if possible. And in ICU settings, they tend to use IV ciprofloxacin if they're unable to use oral doxycycline. So just looking at some methods of prevention, these ticks are repelled by DEET-containing products. So if your exposure to ticks is fairly limited and you know you're going to be exposed, you can use the Tabard and Peaceful Sleep, but they require reapplying every 6 to 8 hours. Then obviously ticks need to be removed, and dogs treated with those ectoparasiticides. Importantly, when you remove ticks, to tell people not to squash them, because apparently there has been a case of tick bite fever from a splash in the eye, squashing one of these ticks, which is a horrible thought. What is also very useful is knowing that the ticks actually need to be attached for about 24 to 48 hours before they transmit the infection. So for people working in the bush a lot or going on trips, a daily skin check in all the little nooks and crannies to look for ticks and pull them off goes a long way in preventing tick bite fever. So the second delightful infection, pediatricians mustn't be confused that I'm going to talk about congenital adrenal hyperplasia. I'm looking at the first picture, but it's just focusing on that rash. It's obviously an adult's back, not a kid's back, but we're looking at human myiasis, which is rather skin crawling condition. And it's also the reason why, moving from Cape Town to the Kruger Park, I had small twins at the time, 6 months old, and done a big order for cloth nappies because that's the right thing to do. And I got to Kruger and I was told by the tanny working at the practice, absolutely not. You cannot use cloth nappies, that your children are going to get mango worm in their bums. So I canceled the order, worried that I can't get my children to sleep or eat or grow or anything. And the last thing I wanted was larvae crawling in their bums. So I'll tell you at the end whether that was a good decision. But basically, human myiasis is infection of a fly larva or maggot in human tissue. And it's caused by the tumbu fly, which is also known as the mango fly or the putzi fly. We do see quite a lot of it in the Lowveld. And essentially, these flies lay eggs on bedding, clothing, or nappies, that are on a wash line, or they lay eggs on the ground in soil or manure, and then clothes are put on top of that. And then 2 to 3 days later, the little larvae hatch. And if they feel nice warm skin next to them, they burrow in and penetrate and form a little papule or boil-like lesion. And I used to send people, so this is an example of one of these little nice boil lesions. And I used to send people home with a little bit of Vaseline and a covering and tell them, just have a look, maybe a little larva will come out. Until I had a consultation where we were chatting for a while afterwards, and the patient said, "Doctor, something's moving under my skin." And I hadn't realized that this process actually takes, it's very quick to get these little larvae out. Whoopsie. So, whoopsie, I want to just press this one. So it only takes about 2 minutes. So it's definitely worth doing in your practice because it's very satisfying to see what you can see. So this is a picture or a little video of a friend of mine's bum. And she wanted the video to show her family. We popped on the Vaseline, and it's probably within 2 or 3 minutes, this little head started poking out and having a little breath of air. So the theory is that the Vaseline suffocates the larva. They can't breathe nicely through that tiny little hole. And so now they want to come out. So I could have just probably removed him at that stage with tweezers, but for some strange reason, I didn't want to hurt him. So we covered him up again, gave him a little bit more time. And this is the same guy. And here just applying pressure on the right-hand side, and he pops out. So they're quite short and stocky, so not a lot of worm that comes out. And if you see over there, he's still sort of wriggling around on the skin. So sometimes those little boil-like lesions have a little bit of a staph infection and need a bit of an antibiotic, but often just getting rid of that larva is enough, and that heals it. So essentially, was it worth me spending all that money on disposable nappies and filling up landfills with disposable nappies? And I don't think so, not at all. To prevent these infections, the clothes can either be ironed or the nappy liners ironed. Pre all the ESCOM drama, you could probably use a tumble dryer and dry that, and those would kill the little eggs. But otherwise, this is a very simple and easy process. So a little papule, put a little Vaseline, and out it comes. So definitely worth saving money and getting the cloth nappies. There's just a little container of these little larvae crawling around. Ugh. Okay, and then the last skin crawling infection I'm just going to mention that we also see quite often, cutaneous larva migrans. And most of the cases that I've seen have followed the typical sort of history, mainly lesions on the feet, and the patient comes having been treated for a little while with fungal creams for the feet and not getting better. And it's, of course, you'll remember that it's the hookworm causing this quite interesting sort of itchy lesion. And most of those people that I've seen from this side have gone on a beach holiday to Mozambique and walked around a lot barefoot. It can also be babies sitting in the sand. And essentially it's the dogs or cats, and they do their business in the soil, and they've obviously got an infection of the hookworm, and these eggs then hatch within a day. The larvae hatch within a day of being pooped out in the soil, and they enter human skin. The rash will start with a little papule, and then it becomes this serpiginous rash, commonly with a lot of pruritus. So a leading edge, looking just like a fungal infection. And then it continues to move and advance about 1 centimeter or 2 every day. What is quite interesting about this is it's actually self-limiting and will eventually go away because the organisms are actually unable to penetrate that basement membrane. However, it's terribly itchy and it'll drive people mad, especially at nighttime when they sleep. And this migration of this larva can continue on for months. So much kinder to treat with albendazole orally, which works very, very well. And that is my presentation. I hope it's been helpful and will spark some memories when you see patients with similar type lesions.
Fantastic, Julia. Thank you so much for giving us insights into the joys of rural medicine and things that we may not know how to deal with, even though we think we know lots of things. So very, very practical, interesting, and well illustrated. I didn't see any specific questions in the chat. I don't know if I missed anything in the Q&A. I don't think so. If there are subsequent questions, and if you're able to hang around a bit, that would be great. Otherwise, thanks again, and for agreeing to be part of this Saturday morning with your other commitments. So we'll move on to the next talk then, which will be given by Dr. Fikile Mabena, who's a colleague. She's a pediatric infectious disease specialist who works at Chris Hani Baragwanath Academic Hospital. She's also a lecturer at WITS, and she's involved with a PhD at the moment, as far as I know. And we've asked Fikile to speak to us and update us about adenovirus infection, and looking forward to hearing this in light of the concern about a possible link with liver involvement in liver disease. So thanks very much, Fikile. I can see your slides and you can carry on as soon as you're ready. Thanks.
Sorry, I forgot to unmute myself. Hello, everyone, and thank you so much to the organizers for this workshop. I've really enjoyed myself this morning, and I've learned a lot. So I'm going to start by just giving an overview on adenovirus, and then I'm going to talk a bit about this acute hepatitis of unknown etiology, and then some take-home messages to conclude. So adenoviruses are viruses that belong to the family of viruses called Adenoviridae, and they basically get this name from initially being isolated from adenoids, human adenoids in 1953. And they are basically medium-sized viruses, DNA viruses, that are non-enveloped. And there are over 60 of these recognized types or subtypes or serotypes. So basically, from around the first adenovirus to about the 51st adenovirus that was recognized, they were classified as serotypes, particularly because of the typical their makeup and biophysical makeup. And from 51 onwards, though, they, more genotyping was done, and these were then referred to as types instead of serotypes. But basically, all these types and serotypes are then grouped into 7 subgroups of species, again, based on their biochemical or biophysical properties. But also of interest is that these species or subgroups have tropisms associated with them. And so you have that particular subgroups tend to cause particular infections. So for example, A and F typically cause GIT infections, and B, C, and E have been associated with respiratory infections. And another thing about adenoviruses and their makeup is that they make excellent vectors for vaccines. And a recent example is the COVID vaccines, where adenovirus has been used as a vector. And there are properties of adenovirus that make them particularly good vectors. And just to mention 2 of them is that they basically, because they are capable of infecting like a wide range of cells, this makes them good vectors. And another thing is that they are able to produce strong and sustained both innate and adaptive immune responses. So, they make excellent vectors for vaccines as well as cancer therapy. So when it comes to transmission of adenoviruses, this usually happens person to person via respiratory droplets, and of course also contaminated fomites. People can get infected from contaminated fomites, and then conjunctival and fecal oral route transmission can also occur. The incubation period is relatively short, about 2 to 14 days. And after the primary infection, individuals will usually develop or produce neutralizing antibodies, and these neutralizing antibodies are believed to be protective, lifelong, to the particular subtype of adenovirus that the person has been infected with. And there are also individuals after this initial infection that will continue to shed adenovirus in RESP and GIT secretions. They will continue to shed these for weeks and sometimes months. And so when we look generally at, who gets infected with adenoviruses, it's mainly young children. By the age of 5, a lot of people have already been infected by at least one adenovirus subtype, and the peak incidence is around 2 years of age. And in South Africa, in studies that basically looked at childhood cases of pneumonia, they did nasopharyngeal aspirate testing, PCR testing, and they found a prevalence of about 90 to 26% adenoviruses. So generally, adenoviruses will cause mild self-limiting disease in immune-competent children. When it comes to severe disease, there are studies that have, indicated that when you look at groups of children that have pneumonia, that you are seeing an increase basically in pneumonia that are as a result of adenoviruses. But equally, both locally and internationally, there are studies also on the other side that show that, when you look at groups of children with pneumonia and you compare them with population controls, that you find that, the prevalence is about the same. But what isn't in dispute is that we know that the younger infants and immune-compromised hosts do tend to have more severe infections of adenovirus that can also be life-threatening. We also, from data, have seen that particular adenovirus subtypes and types have been implicated in causing severe and fatal necrotizing pneumonias. It has also been established that after bronchiolitis or pneumonia, that some babies will develop long-term sequelae following infection, and these can be what pediatricians will recognize bronchiolitis obliterans, and in some cases bronchiectasis. So I'd just like to stop here and just speak on the adenovirus and the immune compromise. I think that's probably a talk all on its own, but I'm just going to make a few points just to remember relating to immunocompromised patients and adenovirus. So basically, in the past few decades, adenovirus has really emerged as an important virus in immune-compromised children and people in general. So both those with primary immune deficiencies and secondary immune deficiencies, and particularly in transplant patients. So they have been known to develop a wider range of disease presentation, different from immune-competent children, and they also have developed severer disease, and their diagnosis is different, is made difficult, I suppose, by the shedding that I mentioned earlier. So the diagnosis in these children slightly more difficult and different from immune-competent children, and also the management tends to be different, where we know that there aren't any antivirals for adenovirus, and there aren't, but some antivirals might be used when it comes to compromised patients. And I think that's all I say about them. I think, this deserves a talk all on its own, the immune-compromised adenoviruses. So just moving on to the presentation. So, I mean, after infection with adenovirus, myriad of presentations can follow that. And as mentioned, majority of them mild and self-limiting. And pharyngitis, and I'm going to group with conjunctivitis, can present really much as the same entity or separate. And the typical presentation is very much of similar to that of other viruses, with fever and rhinitis. And particularly for this to remember is that cervical lymphadenopathy is often a feature that accompanies this. And then otitis media also with fever and seen more in daycare going children, creche going children. And myocarditis is also an often seen complication, can occur after pneumonia or your bronchiolitis, and neurological disease can also occur either as an aseptic meningitis. Tends to be more severe when seen in the immune compromised, as well as hepatitis has been seen, but more described in the immune compromised patients and also more severe. Cystitis, also usually a hemorrhagic cystitis, also self-limiting, but can last up to 2 weeks. But important to note that, you know, with the cystitis, which can be quite scary when you see it, does not have like hypertension or proteinuria, which glomerulonephritis might have. But the cystitis also can be quite severe in the immune compromised patients. So the bronchiolitis, very important that we see in young infants, and a lot of people who work in pediatrics will recognize this patient that I think I was talking to a colleague who's in ICU about a similar patient who had a bronchiolitis / pneumonia presenting with very severe symptoms requiring ventilation. And just to also mention about gastroenteritis is that, you know, these adenoviruses that are implicated in viral gastroenteritis are typically subtypes 40 and 41. And together with rota and noro, adeno is emerging as an important acute viral gastroenteritis virus, not only in community-acquired gastro, but also in hospital-acquired gastro. And then this pneumonia, when it does happen, can be quite severe with progression of dyspnea and often requiring ventilation with bilateral pulmonary infiltrate, very viral looking, in inverted commas, X-ray radiology pictures, and often with negative bacterial cultures and typically not responsive to antibiotic therapy. So when it comes to the diagnosis of adenovirus, serology is not really used. A lot of babies, very young, will have been exposed to adenovirus and will have antibodies. When it comes to antigen detection tests, we've got DFA, which can be used, but the problem with DFA is the decreased sensitivity, and PCR really is what is more used to make a diagnosis of adenovirus clinically and in the clinical setting. And usually adeno forms part of various panels, respiratory viral panels. Virus isolation is still the gold standard, but it is cumbersome and is not usually the first stop when clinicians are wanting of adenovirus. Prevention and treatment, as mentioned, majority of infections will be mild, but for the severe infections, it's really a matter of supportive management with antipyretics, oxygen, may need ventilation, and also to manage the different complications that come up. And just to note that, as mentioned before, there are no antiviral drugs that are available to treat adenovirus, as well as there is no vaccine that is available to the general public for use. There's also, when talking about prevention, important to mention that, you know, contact precautions like hand washing, particularly hand washing with soap, very important for adenovirus, because it's a non-enveloped virus. It won't respond to lipid disinfectants, and therefore hand washing with soap is important, but it will be killed off by heat, and bleach and formaldehyde will kill it as well. And then it's important to clean the environment. And just on environment, just to mention also, chlorinating pools appropriately is also one way of ensuring, particularly for the conjunctivitis and pharyngitis. Limitations. Okay, I'm going to...
Fikile, sorry to interrupt, it's James here. Just noticing that we sometimes losing your sound. I'm not sure if it's your connection or if it's how close you are to the mic, but if you can just maybe try and keep close to the mic if that's the issue. I'm not sure if that's what it is. Thanks.
Maybe it is my connection. I've been sitting at the same spot, but I'll try and come closer.
Thanks.
Okay. So I'm going to switch track now to acute hepatitis of unknown etiology. And just the background that in April of this year, as we all probably know, the WHO issued a health alert about cases of acute severe hepatitis in children. And these were initially reported from the UK, and these were cases of hepatitis from children that had previously been well, young children, initially less than 10 years of age, and they developed the severe hepatitis that in some children required liver transplantation, and as well as resulting in death in some of the children. And this hepatitis was not caused by any of the known hepatitis viruses. And very soon after that, SARS-CoV-2 was kind of implicated, or rather investigated as a possible cause, and then on its track soon after that, adenovirus was also investigated and is still being investigated as a possible cause. Also, just important to note that no travel, diet, toxins, or water source association has been made with any of the cases that have been identified. Where we are now, there was the disease outbreak news, the WHO, that came out on the 24th of June, is that at the moment, there are 920 cases probable cases that have been identified. And these span over 5 WHO regions. And of these 920 cases, 327 have tested positive for adenovirus using PCR. And of these adenovirus cases, 44 are the subtype 41 that is known to usually cause gastroenteritis. And then 45 required liver transplantation, and 64 of these were positive for SARS-CoV-2 on PCR. When looking at the clinical presentation of a group of the over 100 of the cases presenting in the UK, their presentation was quite typical of hepatitis, not with any features that stood out, and they presented with jaundice and vomiting, and the stated clinical features in order of how common they were seen. So, as it is right now, we do not know what the etiology of this hepatitis is, but there are a few theories out there as to what if adenovirus is indeed one of the etiological causes. Why it is that adenovirus, which is a virus that has previously caused mild infections in children, why would it then now cause this severe hepatitis? And one of the theories is that there's during COVID there had been a lack of exposure to pathogens, and then what this does was maybe make children more susceptible to adenovirus later on. Now that now they are back out in the open, and maybe because children were not exposed to all other pathogens. Now they are being exposed to adenovirus, and then the immune system are reacting different to the known adenovirus, but their presentation now becomes becomes rarer. So that's one theory. And another theory is that similar to other viral pathogens, respiratory pathogens, which we saw kind of disappear in inverted commas during COVID, and then only to come back as massive waves after COVID, that adenovirus is probably doing the same, but also coming back with a different kind of presentation. Another theory is that maybe there is another cofactor. There is whether it's another organism or an environmental factor that together with adenovirus is making, the presentation of the children now, different from what adenovirus typically causes in young children. Again, there's also a theory that this could be a novel adenovirus. Unfortunately, so far, all the PCR tests have been from blood and not from plasma, and the concentration has been quite low. So far, no whole genomic sequencing has been done to be able to indeed say whether this is a novel adenovirus or not. But these studies are still underway. This investigation is still underway, and hopefully, if they do get to do whole genome sequencing and see is this indeed a different novel adenovirus that is causing, we'll be able to determine that. However, not everybody sold on the adenovirus theory in general, and one of the reasons is because in all the samples that have been sampled, none of them have been of liver tissue. So even, of the liver tissues that have been sampled, none have had adenovirus. So, so because of this, some people are saying that this association could possibly just be coincidental, that really there isn't really, adenovirus isn't really the cause of this hepatitis. SARS-CoV-2 is also another suspect in this, and again, SARS-CoV-2 is thought of as possibly being a cofactor maybe to adenovirus, because there have been cases that have been found of just SARS-CoV that have been positive to SARS-CoV-2, and there have been cases as well that have been that have had SARS-CoV-2 as well as adenovirus co-infection. So is SARS-CoV-2 maybe a cofactor and is then leading to this hepatitis as a result of adenovirus? The jury's still out. And also another theory is that this could well still be a post-infectious sequelae of SARS-CoV-2, that the hepatitis could indeed be a post-infectious sequelae, kind of falling in the realm of multisystemic inflammatory disease. And of course, there's worries out there, and we all know about the vaccine hesitancy that happened around the COVID vaccinations. And of course, there was also a worry about whether COVID vaccinations were associated. But as it is, this can be categorically ruled out because the majority of the patients were very young and had not been eligible or had not received COVID vaccination. So this is where we are right now with kind of what we are thinking, what we know, what we don't know. But however, I think, much as it is very crucial and important for us to find the underlying cause. The fact that these hepatitis causes such severe disease requiring transplant in some children and causing death, I think particularly in our setting where, if a child were to need transplant, their chances of getting it would be so minimal. I think it becomes important for us as clinicians to have a high index of suspicion for cases like this, and to be able to make diagnosis early on, case definition, to be able to identify the patients early, so that we are indeed able to hopefully halt the progression of the hepatitis. So the WHO has a working case definition, as well as the NICD of who it is that should be notified and who to look out for and who to investigate for this hepatitis. It's important also just to say that, you know, when seeing these children, obviously to have a differential diagnosis, high index of suspicion, but to have a differential diagnosis also, and to exclude the commoner things, the viruses that we know typically cause hepatitis, to also think about other organisms and to remember toxins and drugs as well. And also remember also to look out SARS-CoV-2 in all the cases. And you know, the kind of stools that can be sent in are mentioned, and also there's also numbers that are available for the NICD to be able to notify cases as they come up. Some take-home messages is that adenoviruses are mainly cause self-limiting infections in young children. However, they can cause severe infections and the immune compromised, as well as in young infants. There is this acute severe hepatitis in children that we've seen. We need to have a high index of suspicion as clinicians, as adenovirus has been implicated in this condition, but we still don't know what is the case. And as the studies are ongoing, it's important for us to do early case identification. And I stop here.
Fikile, thanks a lot for doing this talk and for just updating everybody's awareness about our old foe, adenovirus, and perhaps a potential new kind of manifestation of it. I think there's still uncertainty. We seem to have been spared some of the more severe spectrum in our local setting as compared to what's been experienced in North America and Europe. But we did want to highlight this, and also for showing us the links and the possibility of further investigating this. So the NICD has set up you know, a clinical case definition and a process for having specimens submitted where indicated. So this will be made available, and thanks very much for highlighting that. If you can maybe just have a look at the chat, there's one or two questions, I think, Fikile, that you may want to just respond to. But I think, thanks again for the talk. Appreciate that. It's very current and it's evolving. But we'll move on to the final input, which everybody knows, if Lucille Blumberg's giving us pearls and pointers, you dare not miss those. And so we've held that to the end, and thank you so much for almost everybody being able to stay, even though we are a little bit over time. So I'll do a farewell after Lucille's just had her final say and some take homes and pointers. Thanks, Lucille.
So thanks very much. I've cut some of the slides off. So it's really a very short Pearl presentation, just to remind you that medicine is full of surprises. Rare things do occur, and we've heard a number of them mentioned this morning, and we all need to be updated, but common infections occur commonly, and we really need to apply basic principles of diagnosis and management. So to remind you, as we move into the malaria season, to have a high index of suspicion for malaria, always ask a travel history of where they live, and any patient with fever, flu-like illness, acute progressive illness, especially if there's travel to malaria areas or residence in an area, is malaria until disproved, irrespective of consideration for COVID-19 or influenza. Both are kind of current. We've had a number of disasters. People reach for the COVID test, don't ask a history, and patients develop severe malaria, and we've had some fatal outcomes. You have to confirm the diagnosis, either a smear or an RDT, urgently, your responsibility to get results, and repeat if negative. To remind you that CAR-TEM is indicated for uncomplicated malaria in all age groups and in all pregnant women in all trimesters, and artesunate is the drug of choice for severe malaria, or where you are concerned that there may be a patient who kind of, you just think has got severe malaria. You can't quite put your finger on it, but your gut feel said, not good. Start artesunate, give it for 24 hours and move on. We're looking at resistance. It's not a major issue. I think the biggest issue is late treatment at the moment. Artesunate can be used at all age groups, all weight, children of any weight, and can also be used in all trimesters of pregnancy. Don't forget that occasionally malaria mosquitoes travel. Most are uninfected, most don't survive the journey. When they reach somewhere, they're hungry. So even without a travel history, any unexplained acute febrile illness, look at a peripheral blood smear. If there's a thrombocytopenia, that's your clue to definitely look. And this was a patient, in fact, some years ago, Helena saw the patient. You see how things go wrong. It was December, it was in Cape Town. The family came from northern Namibia. They knew malaria well, but forgotten on holiday. Fever, peri-flu, now I guess COVID would be considered. Progressive jaundice, viral hepatitis was looked for. Depressed level of consciousness, meningitis was considered. Child was admitted in dire clinical condition to ICU, and there was a 25% parasitemia. Fortunately, with excellent care, the child survived, but you can see how things go wrong when they're out of context. So we're still in the season for this disease. Usually the history is of a healthy patient, often a very young patient, sometimes a young student. Well, next day, progressive illness and multiple visits to a health facility. They come in with fever, given an antipyretic, then vomiting, given something, then lethargic, and really within hours, there's rapid progression. Sometimes you see petechia. Look at the back of the limbs and the buttocks and the conjunctiva, and before you know it, you have an ecchymosis. So meningococcemia is difficult to diagnose. Meningitis is easy, but the classic here is multiple visits and within a very short time and very little to find. Think about meningococcemia. Often low white cells, moderately reduced platelets, and a CSF that's non-specific. Couple of cells, gram stain, which is negative. Just think about it in children and rapidly give ceftriaxone. It's life-saving. This was a child, 15 years old in Johannesburg. Why would a child with fever, headache, and sore throat come to an emergency department at 2 o'clock in the morning? There's got to be more to it. The full blood count was normal. Antipyretic was given. A macrolide was given. A chest x-ray was even done. So there was something that was worrying the doctor. The next day, vomiting, lethargic, abdominal pain. The ED doctor ordered a CAT scan. It was normal and an anti-emetic. White cells that were alarming leukopenia, moderate thrombocytopenia, and an hour later the child was dead. There was no ecchymotic rash, there was no bleeding, but in fact there was Neisseria meningitidis isolated from the blood culture. So, it's often a gut feeling and unusual, but rapid deterioration. Just remember that all the pieces of the puzzle must fit. And I love Helena's history on play and stay, school and travel. What does your family do? What have you been exposed to? What's in the area? What vaccines have you had? Any skin lesions, progression of illness, and some basic bloods. But put everything together. The exposures, the likelihood of that disease in this patient in that area, plus the clinical findings, plus the laboratory findings, some quite basic ones. Do they fit with what you're coming up with? And if they don't, one of them is wrong. Either your history isn't intensive enough, you've missed some clinical signs, you've asked for the wrong laboratory test, or you've got a result that's not of good quality. So this is a child, a young person I had this week, traveled with mum, going to work in a country in West Africa. The young person had come from the UK kind of the day before and had been in the UK for 10 days. When they arrived in West Africa, child had fever, headache, myalgia, fatigue, and malaria test positive, apparently a smear, typhoid test positive, apparently a rapid serological test in the emergency department, and then subsequently a COVID test positive. So this cannot fit with malaria. There's no likely exposure unless the mosquito traveled on the aeroplane. I think the malaria smear was false. They're not always correct. The typhoid test wasn't one of those awful rapid tests, and serology is not very helpful, as we heard, non-specific, not always sensitive. And in fact, the child had COVID. Usually it's the other way around, and did very well. So this is what we're getting at the moment, dozens and dozens of requests for monkeypox PCR. Patient on the left, I think you can make the diagnosis quite quickly. Vesicular lesions at different stages of development, mainly on the trunk and face, and that is chickenpox. I've never seen so many chickenpox in all my life. The second patient was one of a cluster of patients in a creche in Limpopo province, vesicles on the palms, couple in the mouth, couple around the lips. We got sent for a monkeypox PCR. And this, in fact, was hand, foot, and mouth. So we've had everything from impetigo to scabies and endless chickenpox. So what about monkeypox in children? Well, the outbreak at the moment in the non-endemic areas is in a specific group. It's men. I think there's been one child that might have had exposure to some scales on some tiles, we don't really know. But in endemic areas, quite a lot of children who do have monkeypox, but that's not what we're seeing here. We're not an endemic area. And that's the classical monkeypox from West Africa or Central Africa. Lesions, vesicular, often at the same stage of development, often on the arms, the limbs, the face, but really very different to some of the rashes and requests that we're receiving now. So this is my last slide. Just remember about unexplained progressive multisystem illness. There's a very broad differential. Don't miss malaria. Low platelets, always think of malaria. Progressive fatal encephalitis, especially if there's a normal CSF, normal CAT scan. Think rabies. Think about what's happening at the moment. We've got lots of influenza. We've got some measles popping up. There's polio on our doorstep. I think all vaccine preventable infections are going to increase because of EPI issues in the last 2 years. We're seeing a lot of norovirus, and we're seeing quite a lot of typhoid in some of the provinces. Always remember infection prevention and control, and don't forget about yourselves. If you have a needle stick injury or a splash, not only about hepatitis B and HIV, go back to that patient. Be careful of the septicemia diagnosis. Perhaps it is something else, and always take care. So thank you very much for attending, and thanks very much to Marty and James for organizing and fantastic talks today.